If you don't do either pre-test or post-test, the certificate will not be issued. So it is requested that all of you must do the pre-test as well as post-test, and also you can share your email IDs in the chat group. So if there is any reference material, we have discussed with NHSRC team, so they might be sharing the reference material with you on the email also, the soft copies of those. Ranjit sir, how long? Maybe we can give 5 more minutes for the pre-test.
Yes, ma'am. Our ED sir is coming. I'll let you know, but it will start by 3:35. We will start the session.
Correct. So about 10 minutes more we can give for more participants to join, and in the meanwhile they can do the pre-test as well.
Dear all, the link for the pre-test has been shared in the chat box. Please, I request you to kindly attempt it. Thank you so much.
लॉकडाउन है
146 जो है।
आज थोड़े लोग कम
Yes.
है नॉर्मली 200 300 ऐसे ही होते थे
Welcome, Dr. Kalra.
Good afternoon, ma'am.
Yes. Good afternoon, Dr. Srivastav, sir.
good afternoon how are you nice
I'm
to
good,
nice.
sir. How are you doing?
Good nice
So can't afford to miss this opportunity.
Good afternoon, sir.
good afternoon yeah, can we start
Okay. A very good afternoon, everyone. I, Shreya Srivastav, on behalf of Quality and Patient Safety Division, National Health Systems Resource Center, New Delhi, extend a warm welcome to our chief guest, Major General Professor Dr. Atul Kotwal, sir, Sena Medal, Vishisht Seva Medal, Executive Director, NHSRC. Dr. J.N. Srivastav Sir, Advisor, QPS Division, NHSRC. Group Captain, Dr. Rajiv Patni Sir, Designated Advisor, NHSRC. Dr. Vandana Bagga Ma'am, CMO, SAG, former Director, DGHS, GNC TD, and to all the participants to the 33rd session of STG series. I also welcome our guest speakers, Dr. Pallavi Shukla, Associate Professor, Preventive Oncology, IRCH, Dr. Kaushal Kalra, DM Medical Oncology, VMMC and Safdarjung Hospital, New Delhi. Now, I would request Dr. J.N. Srivastav Sir, Advisor QPS, to please address the gathering. Over to you, sir.
Thank you, Shreya. A very good afternoon to all the colleagues who have joined. So at the outset, it is my proud privilege to welcome Major General Professor Atul Kotwal sir, Executive Director, NHSRC, both the eminent speakers, Professor Kaushal Kalra, Dr. Pallavi Shukla, and of course, our own Dr. Vandana Bagga, and all the participants, those who have joined from different states, from districts, from different specialty hospitals. For the context setting, in fact, this initiative was started more than, in fact, approximately 3 years back, because this lecture was held 3 years back on the snake bite. And why this thing was started, we all know, and we are privileged that we are in, say, major towns, but our field level functionaries who are posted at primary health centers level, even the community health officers who are there at Ayushman Arogya Mandir's sub-health center level, or even the district hospital, CHCs, or the sub-district hospitals. Largely in these situations, most of them, they are all alone. Hardly any opportunities for the knowledge or the skill upgradation. So we realized that in the field of, if we are there to improve the quality of care in the country, supporting the state, supporting the facilities, and addressing this need, National Health System Resource Center, which is the technical support institution under the Ministry of Health and Family Welfare, and largely extend the technical support to the ministries and also to the state governments, and Delhi Society for Promotion of Rational Use of Drug, led by Professor Sangeeta Sharma, who is not there today, but we are privileged to have Dr. Vandana Bagga today. That we came together that let's work where besides improving the general condition of the hospital, the clinical skills also improve, so that the correct and the rational treatment is, all the clinical conditions are diagnosed properly, and the rational investigations and the treatment are undertaken. And normally, besides addressing, say, relevant clinical problems, we all try to address certain programmatic challenges or certain challenges with the rational prescribing of the medicines. And that's where these two institutions, we have been working relentlessly in this, for this initiative endeavor. And it has given a lot of encouraging results. Like today also, we must acknowledge and appreciate that there are about 160 logged in, but at many places, there are more than, in fact, the one person who is listening, who will be listening this conversation. For example, like today in this room, including our Executive Director, Major General Professor Atul Kotwal sir, there are other 6 participants who are present over here. And I also take this opportunity to welcome my replacement, my successor, Group Captain Rajiv Patni. I will remain associated with this program, but in a different role. So he will be leading all these efforts. Before I log off, a special request to all the participants that please do whatever your queries, concerns are there, please post in the chat box. And normally, and we will request to both the eminent speakers and of course Dr. Vandana Bagga that whatever the concerns are coming, if possible, please try to address, respond to them. That would be a big, in fact, the benefit of this lecture series. So once again, a very warm welcome to all of you. And I would request now our Executive Director, Major General Professor Atul Kotwal, to address all of you. And then we begin with the technical session. Thank you very much.
Thank you, sir. A very good afternoon to you all. And especially the 156 participants, rather, those are the number of places where the participants have logged in. And as Dr. J.N. Shrivastava just mentioned, that few places there might be more than one person attending. So overall attendance is more as such. So before I begin, I must compliment the Quality and Patient Safety Division of NHSRC, ably led by Dr. J.N. Shrivastava sir, and DSPRUD with earlier one move an army kind of organization. Now I'm very happy to see Dr. Vandana Bagga is also associated with that. So Dr. Sangeeta Sharma and her entire team who have been, working tirelessly along with QPS team here to improve the practices on ground. And we all know the importance of quality, patient safety, and the kind of trust which people will eventually have is only be possible only when people are able to provide safe and quality and timely and effective and efficient services. And for that, all these efforts are being taken. This is the third STG series and ninth session that in the third STG series. More than 12,000 healthcare professionals have till date attended starting from the first session of the first series of STG. And we get excellent feedback also. And the topics generally are chosen as per the feedback which we receive. So today's topic, as we know, is very, very important. Cancers, NCDs are increasing with 63 to 66% of mortality in India attributable to non-communicable diseases. Of course, that also includes the RTAs and road traffic accidents and all also. But for cancers, the estimated burden, if you see, in 2022, it was 14 point some lakhs, going up to 15 lakh per annum by 2025. And there are more than 8 lakh deaths per annum. And if you see even 14.5 lakh, the older figure, and a district with a population of 10 lakh will have almost 1,040 odd cases, fresh cases every year. So that's the kind of burden we are talking about. And that's why today we have speakers, Dr. Pallavi and Dr. Kaushal, and of course Dr. Vandana Bagga also later on about the program aspects. So Dr. Pallavi will be talking about prevention and promotion. So that becomes very important. When we talk of cancer, first thing which comes to our mind is screening. Screening is secondary prevention. It has already taken place. Very, very important. Yes, it is required because late diagnosis obviously leads to more complications and also more expenditure, more morbidity, and more mortality. But we must strengthen our efforts of health, prevention of cancers and also health promotion. And that's why at the Ayushman Arogya Mandir, these wellness activities and information, education, communication, and behavioral change communication activities are taking place in large numbers and involvement of all the people. We also strengthening community processes, Jan Arogya Samitis, even village health sanitation nutrition committee. So under that, there's a village health sanitation nutrition day, which is observed every month. Till date, it is only RCH focus, reproductive and child health focus. We have now had a discussion with other ministries also to expand the scope and to begin with also include IEC and behavior change communication wellness activity during that opportunity where everyone is there. Instead of only women focused VHSND, we're making ways that how men should also be called for that. We also include screening also there once everyone is there for preventive and promotion activities and all, and also include screening for early diagnosis. So a huge number of screenings in crores are taking place at the arm: hypertension, diabetes, and 3 common cancers. So 3 common cancers, just to repeat, I think all those who are online, they all know, and all of us know, but just to reiterate, cervical, oral, and breast cancer. So even if we target these 3 sincerely, the screening, when we talk of screening, so the healthcare workers have been trained at all levels, but still there is less uptake of cervical cancer screening. There is some hesitancy amongst the healthcare workers, which we know. So for that, we are now planning another round of training, and also involving self-help groups and all, also to reduce the hesitancy among the women for coming forward for screening. So everyone above the age of 30 years has to be screened for these 3 once in 5 years. The numbers are not that many if you look at every Ayushman Arogya Mandir. So it's a very, very doable kind of ask. But what is another important aspect is, one is the quality of our screening. For that, capacity building has to be there. And then in case anyone who's screened positive, then they have to be referred up for confirmation of diagnosis. And in case they are confirmed, then their treatment has to start. And all that referral up and follow up has to be done by healthcare workers at ARM, at sub-center, at PHC, at CHC, and DH, all within the system. And for that, we're leveraging technology with the Aabha ID and integration of all the apps, improving the NCD portal also now, so that can be, utilized at the PHC level by the MOPHC and all the other functionaries in very easy way, instead of the difficulties which they are facing over there. And referral system has to be there. Currently, the referral system is not there. So same app should then be used at CHC and DH also, for anyone who's referred from down below from these arms, or anyone who goes there straight also, the entry is done, and that immediately the CHOs and the MOPHC and ANMs and staff nurses, they know that, okay, so and so from their area has gone directly to CHC or DH, has been screened or has been diagnosed. So they follow them up subsequently. So that kind of system is there, but we all have to work towards that, to how to make it strong. Till then, whatever screenings are done, they have to be referred up, records have to be maintained, and follow-up has to be done at higher facilities, and also when they come back home. And another effort towards strengthening all the activity is district cancer care center. So when the calculation which I shared, 1,000 per 10 lakh, of course, it won't be distributed every 10 lakh. There are states which will have much more. There are certain states which will have lesser number, but that's the average. So each district, that's what Government of India announced in the budget this year. To begin with, 200 districts are being targeted this year. So there are few daycare cancer centers which were approved earlier, but very few of them were functioning very well because a separate budget head and budgeting and guidelines were not available. Now the guidelines have been released. The separate budget is also there. So once these are fully functional, once someone is diagnosed and treatment is started as a tertiary care center at the of state or national level tertiary care center, subsequent cycles, subsequent follow-up can be done at district care center. Additionally, these daycare centers will also work towards prevention and health promotion, and also strengthening the screening services at the arm and at CHC level, so that high quality screening takes place. So I will stop here, but just very happy to see the experts in this field. Dr. Pallavi Shukla, who's a professor in preventive oncology in IRCH. It's within the All India Institute of Medical Sciences, New Delhi. It's a Bhimrao Ambedkar Institute Rotary Cancer Hospital, and she'll be talking about prevention, early detection of cancer at primary setup. Dr. Kaushal Kalra, a renowned medical oncologist, head of medical oncology at Vardhaman Mahavir Medical College and Safdarjung Hospital, will be talking about managing common malignancies in district hospital. And Dr. Vandana Bagga, who's been ex-DGHS of New Delhi, will be talking about challenges in implementation of National Cancer Control Program. So this overall, if you see these three, will give you an idea of not only prevention, promotion, early diagnosis and treatment, disability limitation, rehabilitation, the integrated approach being taken place through the health system when we talk about the implementation challenges on ground. And I'm very, very hopeful that all the specialists, medical officers, staff nurses, CHOs, ANMs, all of you who are joined online with us today will definitely benefit from this. Please ask questions of whatever unanswered issues which are there during the presentation. Please ask them. And if any questions remain unanswered, please email them later on also. So my team, I'm very sure of QPS team will be very happy to interact with you and engage with you. And even capacity building, I would request you that in capacity building, as I mentioned earlier, training have been done. So in case you need another round of training, you need some kind of some discussion on that also. Please share those inputs also. So we will see how our CP division, which is making the integrated modules, how they can immediately connect with some national trainers, or we can see, taking your feedback, what else can we write in our integrated modules, how we can improve our trainings for the next round of training. So that input also you please give us. So once again, congratulations to the QPS team and the SPRUD team, and I must thank all the participants from all over the country. Saturday afternoon, but it's very heartening that we get large number of healthcare workers who join us on such occasions and benefit from this. Thank you. Wish you all the very best.
Thank you so much, sir, for your kind words. With this, I would like to invite our first guest speaker, Dr. Pallavi Shukla, Associate Professor, Preventive Oncology at IRCH. She's a medical graduate from KGMC, PhD from AIIMS, New Delhi, and a diploma in hospital management from NIHFW. She has led multiple projects on cancer prevention, including mobile health interventions, HPV vaccination and screening strategies, AI-assisted detection, and health system strengthening for non-communicable diseases. Along with that, she has authored 18 indexed papers, several non-indexed articles, book chapters, and government training manuals. She is a recipient of Best PhD Award AIIMS, Best Paper Award at national conferences, and recognition for poster presentations and program evaluations. Along with that, she is a lifetime member of EORTC Europe, Indian Association of Cancer Research, and Indian Public Health Association. She is an active participant in national technical and policy committees, including NPCDCS, Task Force, and Niti Aayog Review Committee. Today, she'll be taking up the session on prevention and early detection of cancers at primary care setup. Over to you, ma'am.
A very good afternoon, and thank you so much, NHSRC and DSPRUD, for inviting me for this talk. Thank you so much, Major General Professor Kotwal sir, Dr. Jain Srivastav sir, and Group Captain Dr. Rajiv Patni sir, along with Dr. Vandana Bagga madam, for having me here today. So, as sir has very beautifully summarized what exactly we are going to see in the upcoming sessions, I will just begin to share my presentation. Can anyone confirm if my slides are visible and moving?
Yes, they are visible, Dr. Pallavi, and moving very well.
Thank you, ma'am. So, prevention and early detection of cancer at primary care setup. Now, why are we actually talking about cancers at primary care setup is well answered by Kotwal sir and also by the statistics that we get from India, that we now have ever increasing number of cancers. So every year we are adding a chunk of more than 14 lakh new cases to this burden. And the topmost cancers are the breast cancers, the lip and oral cavity cancers, and the cancer of cervix uteri. Despite the fact that these three cancers are the ones which can be prevented to a certain extent and can be detected at a very early stage to ensure better survival. Despite this fact, we are yet having the huge burden of these three cancers. And screening or early detection is something which we do not expect to happen at a tertiary cancer care centers. Why? Because people who are who need to be screened are healthy individuals, asymptomatic individuals, and they cannot be asked to travel so much for just undergoing a simple screening test, which can be taken up at a primary care setup. Secondly, why it is important to talk about cancers at primary care setup is because that is the first point of contact for any public health facility. And the individuals, they find it very easy, comfortable, and also they're so well versed with the system in their vicinity. So if such services and such health education is available right at their doorstep, I think it will be more acceptable to them. So that's why we are talking about why we are doing this prevention and early detection at a primary care setup. And as per the program, the National Program for Prevention and Control of Non-Communicable Disease, of which these 3 common cancers are a part of, it is envisaged that the ASHA workers, the ground level grassroots workers, are supposed to go door to door filling their CBAT form, a form which is actually helpful to assess the overall health of an individual in their area. But more so, it is,
ma'am.
yeah.
Sorry to interrupt.
Yeah.
I would request you to please present your slide in the slide mode. Yes.
All right.
Ma'am, you have now it's visible.
Slide.
Yes,
Is
ma'am.
it still
Thank you so much.
moving? Is it still moving?
Yes.
Yes,
Oh.
ma'am. Yes.
Fine. Thank you so much. So yes, so I was saying that ASHA workers are supposed to go door to door doing this community-based assessment checklist filling. And through this checklist, they're actually creating awareness in the community about these 3 cancers and what kind of symptoms are associated with these 3 cancers. That is the value of the CBAT forms that they fill. And as sir has rightly mentioned, that we need to utilize these other avenues of communication and education channels like VHNDs to talk more about these cancers. Now, what they're going to talk about is actually present. The content is there in these slides. So what exactly, let's move forward with these cancers one by one. So I'm beginning with breast cancer, which is the most common cancer. And the cancer can develop in any of the parts that is mentioned in this diagram. So most common cancers are ones which develop in the ducts of the breast. However, it can also develop in the lobules and also in the supportive tissues. So as we are talking about preventions of the cancer, so first and foremost, we need to understand what are the risk factors underlying breast cancer. So we can divide these risk factors for breast cancer into 2 groups. One is the modifiable risk factor and the other is the non-modifiable. As the name implies, modifiable means something in which we can do efforts to minimize those risks. So first and foremost risk factor which comes under this category is obesity. So obesity is responsible for so many other cancers as well as NCDs, and cancers which are actually hormonal dependent are more so which are linked to these obesity based cancers. Especially I'm talking about the post-menopausal obesity. So the breast cancer, the ovarian cancers, the uterine cancers, all of them have an increased risk if somebody is obese, and that too after menopause. Because the fat cells, they are contributing to more and more release of estrogen, and these cancers are estrogen dependent. Another risk factor, a modifiable risk factor, is habits like alcohol. So alcohol increases the risk factor for breast cancer. Then one protective factor for breast cancer is breastfeeding your kid. So breastfeeding your kid is not only important for the baby, as we all know, but it is equally important for the mother as well. And more important is the duration of breastfeeding than the number of kids who have been breastfed. Another risk factor is nulliparity of females who have born their first child after 35 years of age. So that again becomes a modifiable risk factor to a certain extent, because of our changing career options and the way we are taking our life, we are at the personal life is actually taking a back seat, which should not happen, and everything should be taken together. So that is one of the risk factor. Another risk factor is hormonal control, hormonal replacement therapies, which sometimes is actually essential because we have to give them the protective role of the female hormones when we are talking about cardiac diseases if the menopause happens early. However, it should not be a non-judicious use of these hormonal replacement therapies. Then unwarranted X-ray exposures can also be a risk factor. Then there are certain non-modifiable risk factors in which actually we cannot do anything. We are females and we are at more risk of having this cancer. However, I would not say that males do not have a risk for breast cancer. Females, I mean, if 100 cases of breast cancer we are seeing, 99 would be females, but one of them can be a male. Then increasing age is a risk factor for breast cancer. However, the breast cancer that we are seeing in India is at least happening a decade earlier than their Western counterparts. So we cannot say that it is not happening in the younger age group. Younger age group cancers are actually having a very bad prognostic cancer, which are triple negative. But still, as the age advances, the risk for any cancer increases. Similarly, another non-modifiable risk factor is the kind of family in which we are born, the kind of genes that we are carrying, the mutations that we are carrying in our cells. So that again is a non-modifiable risk factor, but it is very important for us to know about these risk factors as to what is our family history, at least 2 generations above and 1 generation down. We need to know what is happening in the family, because that will play a lot of role when you are deciding your screening strategies and your risk assessment while you're discussing with your doctor. Similarly, genetic mutations play a very big role, and if certain kind of genetic mutation like BRCA1 and BRCA2, they exist in your family, they run in your family, your risk for having this cancer goes many-fold high. Another risk factor in which we do not have any control is early menarche, that is before 12 years of age, and late menopause, that is after 55 years of age, because this gives us a very huge gap, huge duration of the breast to be influenced by the hormonal cycles. So what we can best do to prevent cancer, be watchful of what you are eating. It needs to be a very balanced diet and healthy lifestyle, taking care of your weight, saying no to the bad habits, the alcohol predominantly, but tobacco, maybe not directly linked to breast cancer, but to so many other cancers. Then knowing about your family history and breastfeeding your baby. Another very important step for prevention, though not primary prevention, but secondary prevention, where we are talking about early detection of these cancers, is going ahead for early detection or screening test. Now, what are those tests? So breast cancer screening in India, as per the expert opinion, is clinical breast examination. We do not have enough setups available for a mammography-based screening program in India. And even the dense breast tissue of Indian breast is not so much apt for a mammography-based screening. It has to be done together with clinical breast examination. But by and large, clinical breast examination stands out as the screening technique for a population-based program in India. Breast self-examination, though, may not be considered as a true screening or an early detection tool, but it is a very important tool to make a female aware about her own breast, because it is the female herself who is going to know what is happening to her, provided she knows what she has to see in those tests. So this is what she needs to know. So what will happen if she has breast cancer? The breast will change in its shape or size. There may be a presence of a painless or a painful lump. It doesn't matter if the lump is painless or painful, we have to investigate it. Because we are seeing cases as early as 20 years who are coming up with breast cancer. So we cannot just do away saying that because it is young age, we can leave this lump at. We need to be very sure through mammography, through ultrasound, through other radiological investigations, and through clinical examination that it can be left alone. Second, we also look at the nipples. So if any discharge is coming from the nipple, it needs to be investigated. Any kind of skin changes that you are seeing on the nipple, on the breast, first we have to rule out breast cancer, and then we go ahead with the dermatological investigations. So nipple inversion. So sometimes nipple inversion may be present early in the life as congenital nipple inversions, but that we can actually make out. If you push the nipples from sideways, a congenitally inverted nipple may come out. However, a recent onset nipple inversion is more of a worry and more signifies towards a breast cancer. Then these orange peel appearance that you see on breast, it again is because of the underlying, those ligaments, Cooper's ligament. Because of the cancer infiltration in that ligament, there are chances that the hair follicles, they tend to be pulled inside, and that gives this orange peel appearance. So this again is a marker for underlying breast cancer. Similarly, any dimpling that you observe on the surface of breast. So these are few things that we see during self breast examination and also during a clinical breast examination. And if there is a swelling in the armpit, we cannot ignore it. We have seen cases wherein there was no sign of cancer on the breast per se during clinical examination, but just a swelling in the armpit, which was further investigated and found out to be risen from breast tissue. So it can also be a part of the breast tail that is going in the armpit, and also the axillary lymph nodes, that those are the first nodes to be drained in breast. And if the things are not seen and managed at that stage, female may land up to this stage. Now, pain in breast is one of the symptoms, which is a very common symptom in females, and it may not be necessarily because of breast cancer. So how do we know whether this pain is pain associated with a malignant disease or a non-malignant thing? There are few pointers, like if it is happening bilaterally, lesser likelihood of cancer. If it is happening in a cyclical way, like it is dependent on your menstrual cycles, then again, it's unlikely that it is because of this thing. And if the pain is associated with any lump or any active nipple discharge, then it is more so pointing towards a malignant disease. So pain in breast in cancers happens actually at a very later stage. So, but still, pain in breast, we need to follow up with our doctor. So these are the symptoms that one does get during breast cancer. However, even before you are looking actively for, if you get these symptoms, we can actually look actively for these symptoms while doing a self-breast examination. And similar things, when done by a trained doctor or a nurse or even a CHO, then it becomes a clinical breast examination. So there are few steps of self-breast examination. First is inspection, just looking at yourself in front of the mirror by raising your arms, putting your arms by your side, or bending forward and tightening your hips. So there are few positions in which we do this inspection, and we look for those signs and symptoms which I already mentioned. Another second step is palpation, when you lie down comfortably on a bed with a pillow underneath your back, and then you palpate yourself, your breast, with the help of your flat of the fingers. So ensuring that each nook and corner of the breast is covered. So that's how we do a clinical self-breast examination. Similarly, you stand on the right side of the patient and do the clinical breast examination for them. And while examining the breast, be very mindful that you are doing the examination of the entire breast. You are even looking at the nipple areolar complex. You are palpating that. You are squeezing the nipples to look for any discharge. And in the end, never forget to palpate the axilla as well. Another screening tool that is available is mammography. However, it is recommended that mammography be done only after 45 years of age. Ultrasound for breast is actually not a screening test. However, if you do find any lumps or any nipple discharge or any positive finding on a clinical breast examination, to confirm your findings, you can go ahead with the ultrasound of breast. Another radiological investigation which is very important in breast cancers is MRI, which is recommended for females who have a very strong family history of cancers or have a confirmed genetic mutation for cancers like breast. So that completes my talk on breast cancer. The slides also contain how we actively do this inspection and palpation. So maybe I'll be sharing these slides, and this can be shared with the participants. Now, what is the screening and management algorithm for the breast cancer? So for suppose a CHO or an ANM, she sees a patient in her primary care setting and she finds that there is a lump. So what she will be doing, she will be sending the patient further higher up in the referral channel to a surgeon at a CHC or a DH, where they can also undergo an ultrasound scan, because mammography machines are not available at all the district hospitals and CHCs. And then if it is a benign lump on ultrasound, we can just ask them to do a more frequent follow-ups. However, if there is a suspicious or a malignant lump or suspected nipple discharge, then we can go ahead with an excisional biopsy of the lump. And that nipple discharge can also be sent for cytology at the DH. If it comes out to be malignancy, then they are referred to a medical college or a regional cancer center for further management, because this will require a multi-modality treatment. However, once a person is confirmed and a regime for the chemotherapy regime is fixed for the patient, they can be sent back to the, the centers that Sir was talking about for a hub and spoke model of chemotherapy provision. Those who are CB negative, they re-enter into the primary screening schedule and they're seen after 5 years again. So this completes my breast cancer. Moving on to the cervical cancer, which is again the second most common female cancer. So this point number 2 that you see on the diagram is the cervix of a female reproductive system, which is the mouth of the uterus. And cervical cancer is actually, earlier it used to be present. It was the most common cancer in India, the most common female cancer in India. However, now breast cancer has outnumbered the cervical cancer cases, but still in certain pockets and in certain communities, we have cervical cancer as the most common female cancer. Now, to a certain extent, the cervical cancer has some relation with our socioeconomic profile as well. So if you look at the inequities in the Southeast Asia region of WHO, we see cervical cancer as the second most common female cancer. However, if you look at the WHO's European region, this cervical cancer, you can't even see in this pie. Again, in India, it is the second most common cancer, not only in terms of number, but also in mortality. One good thing about cervical cancer is that it is the only preventable cancer. Mind it, it is the only cancer which can be prevented. Why I'm saying this? Because cervical cancer is the only cancer which has an infective etiology. It's very easy to manage infective diseases than managing a non-infectious diseases, because we know the agent, we can actually target that agent. Similar thing we saw in COVID as well. Though we do not have a medication for COVID, but we do have a vaccine for COVID. So whenever we have an infective etiology, it's easy to handle that disease. So because of the efforts of Dr. Harar Zur Hossain, who received a Nobel Prize also for the same thing, he isolated the oncogenic HPV strain. HPV is a high-risk human papilloma virus. And he said that it is the root cause of cervical cancer, especially the squamous cell carcinoma of the cervix. According to him, HPV is considered to be the necessary but not the sufficient cause for cervical cancer. So what I mean by this statement is that it is essential that there is an HPV infection post that cervical cancer happens. But not all cervical cancers, but not all HPV infections cause cervical cancers. So it's only when the HPV becomes a persistent thing, the virus we are not able to get rid of the body, then only it causes the cytological changes in the cervix. So basically HPV is a most common sexually transmitted infection, and to that extent that around 60 to 70% of people who are sexually active, they will encounter this virus once in their lifetime, at least once in their lifetime. However, by our immunity, we will be able to get rid of this virus 90% of times. But only in the remaining 7 to 8 to 10% of cases, this virus will actually integrate with the host DNA and will cause cytological changes. So, as with any viral disease, even HPV virus has multiple strains. More than 200 strains of HPV have already been identified, and of which nearly 15 have the high-risk oncogenic potential. In India, the most common strain that causes cervical cancer is 16 and 18. it attributes to nearly 80 to 85% of all cervical cancers. No wonder we are having these two strains in almost all the vaccines that we have for HPV. Now, as I mentioned, that HPV infection per se is a risk factor for cervical cancer, but not the sufficient cause. It needs something more to develop into cancer. So what are the determinants for HPV infection as well as for the persistence of this HPV infection are? So women or men in younger age, they are more susceptible to having this infection. And with the number of sex partners that one has, the chances of having different strains of HPV increases. Then the early age of first sexual intercourse, multiparity, these are again few of the determinants which cause persistence of HPV infection. Then smoking and use of oral contraceptive pills. This may also change the local, immune profile of the cervical area, and it may lead to the persistence of this infection. Any other concomitant genital tract infection will add on to the burden of this HPV infection. Somebody who's immunocompromised will definitely have greater difficulty in getting rid of this infection. So that is why being immunocompromised is a determinant for HPV infection as well as for its persistence. So now, another good thing about cervical cancer is that it gives a lot of time for the cancer to develop. So a normal cervix infected by HPV will take around 10 years to develop into the intraepithelial lesions. That will take around more than 4 or 5 years to develop into invasive cancers. What are the signs and symptoms that one has in cervical cancer? The most common signs and symptoms which are directly linked with this is postcoital bleeding, postmenopausal bleeding, and of purulent I would say copious vaginal discharge. Other than that, any kind of gynecological complaint can be associated with cervical cancer: irregular intermenstrual bleeding, blood-stained vaginal discharge, pain during intercourse. And later stages of the disease, we can also have pressure symptoms in the form of pain in lower back and thigh, and passage of urine and stool per vagina, and anorexia and weight loss as with any other cancer. So WHO has taken this drive that they have adopted a global strategy to eliminate cervical cancer by 2020. This was because it is a preventable and treatable cancer if detected early, and also there is a lot of inequity surrounding this cancer. So by elimination, we mean that we will be having incidence less than, that is what is targeted, it will be less than 4 per 100,000 women. And what do we need to do for that? We need to have a life course approach for cervical cancer control, starting from primary prevention, secondary prevention, and then tertiary prevention. So for primary prevention, we are doing HPV vaccination, we are giving them health education, sexuality education, and also telling them about the bad effects of smoking. Then during secondary prevention, we ask females above 30 years of age to undergo screening test, which I will be talking about very soon. And also, if possible, a screen and treat approach so that we can treat the female at the first visit itself. If we cannot manage the conditions here, female will land up with cancer, and then we can manage her through a multimodality treatment that is a part of tertiary prevention. Now, this is the emerging global strategy. So we target that 90% of girls to be fully vaccinated by 15 years of age, 70% of women to be screened by an HPV test or a test which is at par with that, at least twice in their lifetime. And 90% of women who are identified with a cervical disease, they should receive treatment. So these are the various screening modalities for cervical cancer screening. So we have conventional Pap test, the cytology-based screening. We have liquid-based cytology, which actually increases the sensitivity of Pap test. And then we have automated cytology, which again reduces the burden on the pathologist. Then we have an HPV testing, which WHO now recommends as a primary screening test. And for low resource setting, we have tests like visual inspection with acetic acid and visual inspection with Lugol's iodine. Then there are certain newer modalities which actually are not available for routine screenings. So before we venture into these screening tests, let me be very clear with you that cervical screening requires the female to be there in a setup where we can make her lie down in privacy, and then we can visualize her internal organs and then take a sample from that. Barring HPV testing, all these tests require this process. it's only HPV testing that may allow you to have cell sampling as well. So because you want the female, you want to look at the cervix, I would just give you a quick overview on how a gross, grossly the cervix looks at when you're doing a per speculum examination and what actually needs to be seen. So cervix, as you see, it has an endocervical component which is lined by columnar epithelium and an ectocervical component which is lined by a squamous epithelium. And this is the junction wherein the columnar meets the squamous epithelium, and this is called the squamocolumnar junction. So if you see here, this is the squamocolumnar junction. Internally, this is the os that you're looking at. This reddish portion is the columnar epithelium and the pinkish one is the squamous epithelium. Sorry. Now our cervix, our os also sees changes through our life cycle. So before puberty, we see the os to be pinpoint, and this is the squamocolumnar junction beautifully surrounding it. After puberty and during reproductive period, the columnar epithelium tries to push forward out in the ectocervical region. And because now the columnar epithelium has come out on the ectocervix, it is actually exposed to the acidic environment of the vagina, and that's how it will try to change its characteristics. So the columnar epithelium may not be able to survive this environment. So it undergoes metaplasia and it tries to become squamous in nature. So now this, what you are seeing outside, is the old squamocolumnar junction, but because this zone is again becoming squamous in nature, we have a new squamocolumnar junction forming. So the place between the old and the new squamocolumnar junction is actually called the transformation zone. And this is the gray zone in which all the pre-invasive or invasive lesions are seen. This is the place where the cancer begins. And during perimenopausal period and on menopause, the epithelium again tries to recede inwards. So there is a possibility that when we are doing a visual inspection with acetic acid for a postmenopausal female, we might not be able to see the entire transformation zone. So some part of it may have receded inside. So there are chances that we may miss out some cancer in postmenopausal females if we are just doing VIA. But still, VIA is a very good test when we are talking about a primary care setup and we are talking about the nation at large, where we are aiming at doing screening for one and all above 30 years of age. So because we do not have enough resources available for HPV, for Pap test, this is the test of choice as of now. And it is also a test of choice because not much of resources are required, and also you can see the result there and there itself, and you can also try to treat the woman if the lesion is amenable for ablative procedures. So that is one reason why we are actually promoting visual inspection methods for population-based cancer screening. Because what do we require here? We just require an examination table, a light source, a bivalve speculum, an instrument tray, some cotton swabs, examination gloves. That's it. So the only thing that may not be present in the centers which are not doing the test is acetic acid solution, which has to be freshly prepared, and something for sterilization. Now, acetic acid solution, I want to really re-emphasize on this because this has to be freshly prepared. Because recently I got to know that few dispensaries, few centers, just they got to know that acetic acid is needed. They ordered 5% acetic acid from market. Trust me, your 5% acetic acid may not remain 5% the next day, because it is very hygroscopic in nature and it will absorb the moisture, and as it is, it's a very humid environment these days, so it will not remain at the same saturation that we intended at. So making a freshly prepared acetic acid is very important. Then we first inspect the external genitalia after taking consent from the female, then insert the speculum, reveal the cervix, look for any signs of infection, remove the excess discharge by a sterile cotton swab, then identify the cervical os and try to manipulate and see the entire squamocolumnar junction, the old and the new, and the transformation zone. Once you are able to identify the transformation zone, then you take a profuse amount of acetic acid in a cotton swab and apply it to the cervix. Wait for 1 minute. Yes, we have to wait for 1 minute by a stopwatch. And only after 1 minute we inspect this the transformation zone, and then we see the lookout for the lesion. So a very short video. So that's how you expose the cervix. And you dab, and generous amount of acetic acid you're applying there. And by watch, we will be waiting for 1 minute to see the results. So what is a negative finding? So what is the concept behind acetal whitening is the protein in the cancer cell, it undergoes coagulation and it turns white. So the white that you see in VIA, I'll be showing you some images. So that has to be a very sharp, distinct, well-defined, dense, opaque, dull, or white or oyster white areas. And it will be very close to the squamocolumnar junction. And invasive cancer will be very clinically visible in ulceroproliferative growth. So if you see, this is not a VIA positive lesion. This is actually the columnar epithelium which has everted out, and it is called as ectropion. This again, everything that you're seeing here is after the application of acetic acid. Again, the white, the pinkish white thing that you're seeing, this is not the kind of whiteness that we are talking about. Again, this is a pale cervix, pale looking cervix, but this is not an aceto whitening. These patches that you are seeing here, these are the aceto white areas of the cervix. These are the pre-invasive lesions on the upper lip that you are seeing, and also on the lower lip. Again, one big area here and another big area here. So these are the kind of images that you see here. To corroborate your findings of VIA, we can also apply some Lugol iodine after this. And the principle of Lugol iodine, I'll just tell you, just see this video. Once you apply Lugol iodine, the squamous epithelium, it contains glycogen. So all the precancerous lesions and invasive cancers, they have little glycogen. So they will not take the stain. So they will look like negative. Those who take the stain are the normal cells. So squamous epithelium turns mahogany brown if it is negative, and the positive ones will actually be taking up the stain. So it's reverse of what you did in VIA. So once somebody does a VIA at a subcenter or PHC by A&M, CHO or the medical officer, and it is negative, the test has to be repeated after 5 years. But if it is positive, they have to be referred to a gynecologist or a lady medical officer who is trained to do a thermal ablation if it is possible. And lesions which are not eligible for thermal ablative therapies, they can undergo biopsy at a higher facility, at a DH or at a higher facility, and then depending upon the staging and all, they need to be referred to higher centers. And these cases, they have to be followed up after 1 year of VIA. So the lesions which are amenable for screen and treat are the ones which are entirely visible and they're not occupying more than 2 quadrants of cervix. We can do ablation there. The lesions which are entirely located on the ectocervix and are not present inside the cervix, they can be ablated by screen and treat approach. So lesions can be adequately covered by the large. So if we are talking about cryotherapy, we attempt only once, but if it is thermal ablation, we can actually be having overlapping applications as well. So if there is suspicion for invasive cancer, please don't go ahead with the screen and treat approach. So that's how I think now I'll just quickly rush through the oral cancers as well. So oral cancer is a public health problem, but more so for India because we are actually having many cases of oral cancers. So, tobacco can lead to so many cancers, but lung and oral cavity are the direct hit of the tobacco habit. And more than lung, we are having lip and oral cavity cancer. This is actually a cancer of our continent. Why? Because we are tobacco chewers. So what comprises of an oral cavity is this. So the gingiva, the lip, the teeth, the hard palate, the soft palate, the area behind the teeth, the retromolar trigone, the anterior 2/3 of the tongue, the buccal mucosa, and the floor of mouth. So this entire thing comprises of oral cavity, and this is something that testing for this is very easy, and this doesn't require a great deal of expertise, and this doesn't require a separate facility. So this can even be done. So when we are finding it difficulty and challenging to do the breast and the cervical cancer screening, but we don't expect such challenges to be there for oral cavity screening. Now, what are the risk factors for oral cancer? No wonder, no doubt that tobacco is a risk factor for oral cancer, and everybody knows that. And tobacco consumed in any form, be it smoking, be it chewing tobacco, that is a risk factor. Besides tobacco, even areca nut consumption has come out in the in the list of carcinogens. So areca nut, the supari that we casually consume, is also a risk factor for oral cancer. Another risk factor for oral cancer is betel quid, the pan. That we so we think that it is so harmless, but even the pan with areca nut and lime, the tuna that we put on that pan, that can also lead to oral cancers. And the gutka, the mixture of betel quid and tobacco. So all this becomes a part of risk factor profile for oral cancer. Now, alcohol intake in itself, plus even with tobacco together, it forms a big risk for oral cancers. Now, besides these habits, even if somebody is having an ill-fitting denture or a sharp tooth and they're ignoring it, that constant, friction, that constant injury that the teeth is causing in the buccal mucosa, that can also lead to oral cancers. And if we are having a weakened immune system, that also has a role to play in oral cancer risk. Then somebody keeping an poor oral hygiene or lack in low fruit and vegetable intake in their diet, that again is a risk factor for oral cancers. There were certain studies, although we have not been able to put a justified, conclusion. We haven't yet derived such kind of conclusions, but yes, things like lycopene and some of these some of these products can be helpful in protecting oral cancers and even in regressing the oral pre-malignant lesions. Another important risk factor for oropharyngeal cancers is human papilloma virus, the one which we talked about in the cervical cancer. It also has a role to play in oral cancer and largely in the oropharyngeal cancers. Now, what are the common symptoms that we see in oral cancer? So if there is a persistent sore in the mouth or face which is not healing, so more than 2-3 weeks has happened and the sore has not healed, that becomes a symptom. Another is difficulty in opening the mouth. So that happens mostly in the case of submucous fibrosis, that we are having this difficulty in opening the mouth. Then development of the white, red patches or a mixture of both on tongues. So red patches are more aggressive than the white ones. Then chronic pain in the mouth, tongue or jaw. Difficulty in chewing or swallowing. Then swelling or thickening, lumps or bumps on lips, unexplained bleeding in mouth, hoarseness or change of voice, loose teeth, ill-fitting dentures, and unexplained weight loss. So these are few of the common symptoms of oral cancers. And these are few of the oral potentially malignant disorders which have high propensity of developing into cancers later on. So any clinically detected oral mucosal condition this can be a white patch, like you see here. This is a leukoplakia. This one is a proliferative verrucous leukoplakia. Then this red patch that you're seeing here is erythroplakia, and it is more dangerous, more oncogenic potential than leukoplakia. This is the severe case of oral submucous fibrosis that we are seeing. So the mouth opening is restricted to less than 3 fingers, and the initial symptoms of oral submucous fibrosis can just be a burning or tingling sensation in the oral cavity. Now, because tobacco chewing is a habit which is more predominant in Indian subcontinent, we tend to see these tobacco pouch keratosis also, where we find these lesions where the person keeps the tobacco here. And this is the fimbriated pattern of oral lichal planus. So all these conditions, they comprise of, these are the common oral pre-malignant disorders. So the high-risk features are erythroplakia, erythroleukoplakia, or heterogeneous and ulcerated leukoplakias. And the high-risk subsites are if you have something on tongue and the floor of mouth, that is more dangerous than any other site. So what do we do for oral cancer screening? Everybody above 30 years of age, men, women, they need to be screened for oral visual examination. That's just a torchlight examination. And anybody who consumes tobacco and alcohol, for them, age is not a restriction and they have to be screened at any age. So this is how we do a oral visual examination. You first expose on the right side the buccal mucosa, then you just keep on moving ahead on the left side, seeing the upper labial vestibule, then seeing the lower labial vestibule. Then we look for the lesions on the right lateral tongue border. Then similarly on the left lateral tongue border, the floor of the mouth, and the palate, the hard palate and the soft palate. So the examination completes only with the cervical lymph node palpation, the submental, the submandibular, the preauricular, postauricular. So this is the algorithm of what do we do at primary level once we see the person needs to be evaluated by anybody present at the primary facility. And even the ANMs can do this after the training. So the potentially malignant lesions, they are guided for elimination of histological factors and also counseled for tobacco cessation. We observe them for 6 weeks. If the lesion is regressing, we can keep them on regular follow-up. But if there's no regression, we can just schedule them for a biopsy. As for suspected oral cancers and clinically diagnosed oral cancers. And if it comes out to be cancer, they are referred to tertiary cancer centers for further management. What do we do for prevention of oral cancers? So this is the 4-pronged strategy. So one is dietary modification, need to avoid all the spices or the harmful things that are actually causing that lesion. We need to maintain a good oral hygiene, a routine dental visit, and first and foremost is tobacco cessation. So how do we do tobacco cessation? Tobacco is a habit which is not easily undone. So first we should emphasize on the population which is yet not exposed to tobacco to not initiate it at the first instance. Because if you initiate tobacco, it becomes very hard to quit tobacco. And somebody who is in a habit of taking tobacco or alcohol, it's not that they are bad people, but they really need help. Even if they want to quit, they cannot quit without help. Just willpower, just this thing may not be sufficient. So once somebody is addicted, they might be needing something additional. So we as healthcare providers, we have a duty, a responsibility that whosoever comes to our OPD, we should give them the 5 A's of the brief intervention for tobacco cessation. We need to ask them, do you consume tobacco? We need to advise them, because an advice given by a healthcare provider will be 10 times more efficient than somebody else telling them to quit tobacco. And then we need to assess if the person is ready to go ahead with the with the quitting thing. If yes, then we need to assist them in the quitting process, and then we need to arrange for their quitting thing. And we have so many pharmacological interventions together with the behavior therapy. We can actually help everybody quit tobacco. So that's all from my side. I hope I didn't overshoot my time.
Thank you so much, ma'am. It was a very wonderful session. Ma'am, just one question. Would you be taking up the questions right now or at the last of the session?
I am okay to take up the questions now.
Okay, ma'am.
I think we can take 2-3 questions, maybe 4-5 questions right now. By the time Dr. Kaushal is ready with his presentation, and if there are more questions, then rest of the questions we can take at the end of the session. So one question that I can see in the chat box is, what is the age of girl for HPV vaccination?
Yeah, I actually intentionally missed the vaccination part because it's yet not, it is yet not announced by the government of India, though we are planning for the HPV vaccination. The best age for vaccination would be 9 to 14 years because of 2 reasons. One, we need to do the vaccination before the initiation of sexual activity, so that we are prepared for that virus. Whenever it's entering our body, our immune system is ready to fight it back. Second, we are doing it at this stages because this is the optimum time. It's not too early, it's not too late. And the younger, vaccination is given in the younger age, it has a more, efficacious response. So that's why this 9 to 14 age group has been selected.
Secondly, we can also reinforce that vaccination is equally important for boys. So, Dr. Pallavi, would you like to comment on that as well?
So again, I will not say that vaccination is not meant for boys. Yes, definitely, because HPV is not the culprit for just cervical cancer. It also causes penile cancer, anal cancer, oral cancers. However, the way it is attributing to cervical cancer, it is not attributing to that extent to other cancers. So there can be other causes for penile, anal, and penile, anal, and oral cancers. But for cervical cancer, it is HPV. Now, if I divert my, I'm just talking as a public health person. So if I have these many doses of vaccine, I would like to first vaccinate my girls rather than, going in for the boys. But yes, boys ka vaccination is also important.
Because I think there are at least 6 types of cancers that are caused by HPV.
Yes.
So if they ask for it, at least we should be aware that at
Absolutely.
every opportunity of counseling, we must extend this counseling to all the parents, all the beneficiaries as well as their wards. Right. So one question is about the purple coloration.
I'm
The
sorry, what?
question is, yes, so I'll repeat the question. Purple color of cervix leads to positive. They want to know what is the color which is positive
It's
and what is the color
absolutely
which is not
chalky
positive.
white. The white color after VIA. That's what you are asking?
So
After
I think that you can mention both VIA as well as Willy.
So
So you
for
can just repeat the
VIA,
color.
right. So for VIA, the positive is aceto whitening, that is chalky white color. For Willy,
Yes.
it's actually the reverse. The negative stain is the positive test. So if the tissue is not taking iodine stain, would be what? Bluish black in color. So if the tissue is not taking the color, that is positive.
And another question is the current status of mobile education and screening units for oral cancers. I
I'm
don't know
sorry,
if you are aware of that, but
mobile education.
so I think it should be mobile clinics and the community screening, probably they mean to ask.
I mean, it's a very good opportunity. If we can do that, it will be a brilliant idea, because for oral cancer screening, we do not want unnecessarily that people are coming to the clinic just for the oral cancer screening, which can be done at the home facility itself.
So in fact, जब हम आगे बात करेंगे intersectoral coordination की, so education department also becomes very important. We have school health schemes in almost all the states, multiple schemes which are covering the school students. We have regular dental visits of the patients. We have
Absolutely.
regular visits to ENT specialists. So every opportunity should be utilized rather than focusing one specific uh, scheme for that. Yeah. So
Thank you so much,
Dr.
ma'am.
Pallavi. I
Thank
can't
you.
see many more questions now.
Okay, ma'am. Thank you so
That's
much,
to
ma'am.
Team NHSRC now.
Just one last thing. I mean, is it okay if I can leave the session now? Vandana, ma'am?
Vandana, ma'am.
I think it's okay because if more questions come your way,
I
I'm
will
sure
be
you are always
answering them
available.
through mail or
Yes,
either.
yes, definitely.
Thank you so much, Dr. Kalra sir. Hoping to listen to your talks some other time.
Thank you, ma'am.
Meeting you soon. Thank you. Bye bye.
Thank you.
Thank you,
Thank you
ma'am.
so much,
Thank you,
ma'am.
NHSRC.
Thank you so
Thank you,
much,
Dr.
ma'am.
Pallavi, for a wonderful talk. Thank you so much.
Thank you, ma'am.
Moving forward, I would like to invite our second guest speaker, Dr. Kaushal Kalra, DM, Head of the Department of Medical Oncology at Vardhaman Mahavir Medical College and Safdarjung Hospitals, New Delhi. With over 13 years in medical oncology, his expertise is in advanced cancer treatments, including targeted therapy, immunotherapy, and hematologic malignancies. He has pioneered the first bone marrow transplant and a CAR T cell therapy at a central government hospital in India. He's also actively engaged in teaching, training, and mentoring medical students, residents, and fellows. He has published several papers in national and international journals, research and his research focuses on treatment innovations and personalized medicine. Dr. Kalra is also a member of ASCO, that is American Society of Clinical Oncology, and ESMO, European Society for Medical Oncology. Today, he would be taking up the session on managing common malignancies in district hospital. Over to you, sir.
Thank you. Thank you, Dr. J.N. Srivastav, sir. Thank you, Dr. Major General Professor Dr. Atul Kotwal, sir, Dr. Vandana Magga, ma'am, and Group Captain Dr. Rajiv Patil, sir, for giving me this opportunity. Please confirm whether my slides are visible.
Yes, sir,
Yes,
they're
they are
clearly
very much
visible.
visible, Dr. Kaushal.
So, managing common malignancy in district hospital. So, my introductory overview is the overview of this section is cancer burden and risk factors, diagnosis and investigation, treatment approach, local and systemic, site-specific management, breast, cervix, oral and lung cancer, and survival outcomes and blood cancers. So, cancer may be regarded as a group of disease characterized by an abnormal, uncontrolled growth of cells and its ability to invade the tissue and even the distant organs. The eventually death of the affected patient if the tumor has progressed beyond the stage when it can be successfully removed. So there are three types of growths: benign growth, malignant growth, and precancerous growth. Benign growth grow quite slowly. They do not spread. These cells are almost similar to the normal cells. It may cause a problem if they become very large due to compressive symptoms or this uncomfortability of the patient. Malignant, these are the true tumors. These grow faster than the benign. They have ability to spread and destroy the neighboring tissue. And this invade the healthy tissue at the new site. They continue to divide and grow. These secondary sites are known as metastasis. These are called as a metastatic cancer. And third growth is precancerous. These are the abnormal cells, collection of the abnormal cells, which may develop or may not develop into the cancer. Usually they develop in the cancer over the time. There are three major categories of the cancers. Carcinoma, these arises from the epithelial cell lining of the various organ. Sarcomas, these are arise from the mesodermal cells, including in the connective tissues. Other one, lymphoma, myeloma, and leukemia. These arise from the bone marrow cells and immune systems. So certain myths are there. Certain cancer myths are there. Cancer only means death. Cancer is contagious. Cancer is caused due to injuries. It's always painful. All cancer are the same, and cancer is incurable. And list going on. So come to the statistics. According to the Globocan 2020 data in 2020, so approximately 13 lakhs new cases were diagnosed. Most common is the breast, followed by lip and oral cavity, then cervix, lungs, colorectal. These vary as per the age, as per the sex, and number of deaths around 8.5 lakhs. And number of prevalent cases over 5 years are 27 lakhs. Top 5 cancer in the India, in the male, lip and oral cavities comes as well as the number 1. Next, lung, stomach, colorectal, and esophagus. In females, breast, cervix, ovary, lip and oral cavity, and colorectal. These are in the following order. Risk factor already covered by the Dr. Pallavi. The unmodified risk factor like age, sex, race, family history, and modified risk factor, modifiable risk factor like smoking, alcohol consumption, sedentary lifestyles, unhealthy diet, obesity, infection, and sun exposure. Prevention, 4 in 10 cancers can be prevented, which Dr. Pallavi explained very well, like be smoke free, keep a healthy weight, be safe in the sun, avoid certain substance, protect against certain infection, drink less alcohol, eat a healthy fiber diet, avoid unnecessary radiation. Now come to the warning sign of the cancer. when certain warning signs are there, which patient used to come to us OPD, and certain warning signs are there, which general physician can diagnose and they can detect or they can suspect the cancer, and they can go ahead for the workup, for the referral, when these warning signs are present, like unexplained weight loss. Unexplained weight loss are warning sign in the certain malignancy, no other feature, no pain, nothing, only unexplained weight loss. That usually comes in the lymphoma. Patient usually come with the weight loss. Mera weight come ho gaya. In last 1 year, I lost a weight of 10 kg, 15 kg. No other symptom. Like it's a early sign of the colon cancer also, and stomach cancer. It affects your appetite and body's ability to remove waste. In lymphoma, there is splenomegaly is there. Spleen compress the stomach. So that when it's compress the stomach, your appetite will lose. After having only small meal, you are feeling satiety. Patients are feeling satiety. So it's a warning sign, unexplained weight loss. Then shortness of the breath. Lung cancer patient remember noticing this as their first symptoms. And patient, it's a very starting phase. It's very at minor level, very small level. Patient usually neglect. When it approach to the level, then only they used to come to the hospital, and that time, so many times delays, already metastatic cancer. Fatigue. This common symptom should be looked at in the combination with the other symptom. After patients usually complain after having small work, I usually get tired. I don't want to do work. I don't want to walk. Previously, I love to walk, but now I can't. I don't like. Upset stomach cramps, or infrequently upset stomach, sometimes loose stool, change in the bowel habit, sometimes constipation, then pelvic and abdominal pain, rectal bleeding or blood in stool. There is no cause, no pain, nothing. Patient usually say some blood in stool arise from last 1 month, 2 months. This is the common sign of the colorectal cancer. Feeling full or unable to eat, I have already explained. Now, what is the importance of early detection of the cancer? In cancer treatment depends how early you have diagnosed the cancer. After early detection, the disease can be curable, less invasive treatment needed, less trauma, cost effective, and less painful. Like in example, higher 5-year survival rate associated with the early detection of cancer. In the cervix cancer, if it is detected early, 93% patient usually cure. 5-year survival is cure, usually 5 years survival cure. If detected late, only 15% patient survive at the 5-year. Otherwise, 85% patient usually dies. In breast cancer, similarly 93% if detected earlier. If detected late, only 6% patients survive after the 5-year. Similarly, in colon cancer, in early detection, 74% patients survive at the 5-year, while 6% only if it was detected late. In melanoma, 97% cure rate if it is detected early. Otherwise, only 17% patients usually survive after 5 years. The certain tests are there to detect the cancer. There is battery of tests. Some example I have mentioned in this slide, like imaging technique, X-ray, simple X-ray. Patient is having cough and shortness of the breath. Simple X-rays. Certain mass is there. There's blood in sputum is there. No blood in sputum is there. No feature of the infection, etc. CT scan, isotope scan, ultrasound, cold scan, MRI, PET. PET usually not available at the district hospital, tertiary care only. And certain cities also still not available PET. I will explain later. Endoscopic techniques, sigmoidoscopy, proctoscopy, laryngoscopy, bronchoscopy, esophagoscopy, cystoscopy, gastroscopy, and so on. Some biomarkers usually tell us if there is a chances of malignancy, like immunohistochemistry, flow cytometry, Western blot, genomic and proteomic approach, and certain blood tests like CA19.9, CEA, CA125, they also hint about any cancer. Other tests like biopsy. Biopsy is the diagnostic test for diagnosing the diagnosis of the cancer. Biopsy is almost mandatory in almost every cancer. Certain exceptions are there. Otherwise, biopsy is mandatory for the diagnosis. Certain screening tests like blood and serum test, WBC, ESR, serum biochemistry. These are the battery of tests which are needed, and specialists will decide which tests are required, considering the multiple factors in the first. Now come to the contribution to cancer care at a different level. In primary care level, At part of the diagnosis, recognition of the cancer sign and symptom, I have already explained, appropriate clinical evaluation, early referral of the suspicious cases. At the secondary care level and district level, in diagnosis, cytology, biopsy, routine histopathology, X-ray, ultrasound, endoscopy, usually available at the almost every district hospital. Exceptions are there. Treatment modality, moderately complex surgery and outpatient chemotherapy can easily be given at the district hospital. Additional function like coordinating with the primary and tertiary care levels, supporting palliative and survivorship care. At tertiary care level, there is bit advanced like treatment in diagnosis, PET scan facilities available at the tertiary care level. Though it's not available at the so many centers, but near future it will be there. In treatment, radiotherapy, complex surgery, chemotherapy, rehabilitation, additional function like communication with the primary and secondary care level, supportive palliative and survivorship care. Now, approach of the patient for the cancer treatment, there are 5 modalities. Surgery is the mainstay for the solid tumors. Surgery is the only modality which can cure the patient. So it's the most important part of the cancer treatment. If you want to cure the patient, surgery is you can say it's mandatory in solid tumor. Chemotherapy usually kills the cell. Cancer is the uncontrolled growth of the abnormal growth of the cells. So chemotherapy kills the cell. Radiotherapy, radiation therapy, I will explain the mechanism. Next is the hormonal therapy. That also will be, and targeted therapy and immunotherapy. So for the cancer treatment, primary goal is to eradicate the cancer. Next, palliation. Palliation means to decrease the symptom, to overcome the symptoms, to preservation of the quality of life, while striving to extend the life, like pain management. If certain symptoms, pain is the most important symptoms which we have to manage during the cancer patient treatment. This cancer treatment divided into 2 main types: local treatment and systemic treatment. In local, surgery, radiation therapy, and ablative approach. In systemic, chemotherapy, including hormonal therapy, targeted therapy, and biological therapy, including immunotherapy. First, come to the localized cancer treatment. Surgery, the most effective means of treating cancer in at least 40% patients. Means approximately 50 to 60% patients land up in the metastatic stage. Once patient metastasizes, then no role of the curative surgery. Only palliative surgery needed, which is in few patients only. Even when the patient disease is not cured by surgery alone, removal of tumor, local control of tumor, that is the palliation, preservation of the organ function, debulking, and staging information. Sometimes laparoscopic surgery is needed for the staging. Surgery resection can be defined as R0 resection. R0 resection means you excise the tumor completely with an adequate margin of normal tissue. Because whenever the surgery for the cancer patient has been done, that margins has been checked for whether margins are positive or it is negative. If margins are negative, then it is R0 resection. Next, R1 resection. R1 resection means tumor has been completely excised, but margins are microscopically positive. Pathologist says their margins are positive. R2 resection means there is gross residual disease are there. Surgeon could not remove all whole tumor, because while he opened the abdomen or whether the surgery, any surgical part, the surgery was not possible to remove the completely because of the invasion. Sometimes in radiology, imaging, it's not predictive if how invaded the tumor is there. So it's not possible. So R2 resection, sometimes surgeon used to do R2 resection. Next, extending the procedure to resect the draining lymph node, because carcinoma metastasizes to the lymph node only. So draining lymph node sometimes removed by the surgeon, like in CA colon, carcinoma colorectal cancer. Minimum 12 to 14 lymph node must be removed. If he has not removed the adequate lymph node, then it is indication for the chemotherapy. So particular number of lymph node surgeon has to remove during the surgery. And also obtain the prognostic information. If nodes are positive, then it means stage is upgrade the stage, and after that calculation of the as per the stage, the further course of the action will be taken. In some anatomical lesion may improve the survival. Surgery, if chemotherapy is given after the surgery, then it is called the adjuvant therapy. It permits a substantial decrease in the extent of primary surgery. That is, lumpectomy followed by radiotherapy is an effective as modified radical resection. Mastectomy for the breast cancer, limb sparing surgery followed by radiotherapy and chemotherapy replaced amputation. Previously in sarcoma, amputation was needed. So now it's limb sparing surgery followed by radiation therapy and chemotherapy, sometimes it cure. Neoadjuvant therapy, when therapy being given before the surgery, then it's called as a neoadjuvant therapy. Initial chemotherapy and or radiotherapy is delivered. The reason, the rationale for the giving the neoadjuvant therapy is to reduce the size of tumor, to clinically control the undetected metastatic disease, that is colorectal cancer, locally advanced breast cancer. So neoadjuvant therapy given. It is also predictive marker once you have given the neoadjuvant therapy, like in breast cancer, small early breast cancer, we have given the neoadjuvant chemotherapy, then surgery was done. Then pathologists see whether residual tumor is there or not. If residual tumor is not there, then it is pathologically complete remission, pathologically CR. If pathological CR is there, then further treatment after the surgery, it will change. If there is no path CR, if it is residual disease is still there after surgery, then there is no pathological complete remission. Then the treatment will change. So it will detect what further course of action, what further treatment should be given after the surgery. So neoadjuvant therapy is also very important in certain type of tumor. Sometimes surgery can be curative even in metastatic disease. It's a usually rule of thumb, if disease is metastasized, disease spread from one organ to another organ, primary organ to another organ, it is metastatic and it is uncurable. But one term is there, oligometastatic, means only few metastatic, only on a few sites, like less than 5 metastases at less than 1 or 2 sites. So metastatic, oligometastatic disease. If it can be removed by the surgery, surgeon says, okay, I will remove this. Then also in metastatic disease also can be tried as a curative intent. Surgery can be tried. So we used to give chemotherapy as we are giving in curative intent, because treatment sometimes differ, whether you are giving in curative setting and whether you are giving in palliative setting. In curative setting, you have to go aggressive. In palliative setting, you have to take care of the patient's quality of life also. The example of oligometastatic lung mets like osteosarcoma. Sometimes osteosarcoma is very chemo-resistant, radio-resistant, very difficult to treat. If removed by surgery, okay. But if it is metastasized to the other organ, then it is patient has been gone like that. No treatment, because very least responsive to chemotherapy. But if oligometastatic, only few mets are there lung, so we request surgeon, please go ahead and remove this metastasis also, so that we can try for the cure of the patient. Similarly, in the colon cancer, if only few metastases at the liver, then we ask the patient, we ask the surgeon, we request the surgeon, please do the lobectomy or metastectomy also, so that we can give one fair chance to survive, fair chance of the cure of the patient. Surgery can also associate with the symptomatic anti-tumor effect in hormonally responsive tumor, oophorectomy in breast cancer. Like if the premenopausal woman, she developed hormone positive breast cancer. Hormone is the culprit which caused the breast cancer in that lady. So either she has to take the oral hormonal therapy, or that is medical oophorectomy, or we can ask the surgeon to go to the oophorectomy. When you are removing the breast, you remove this ovary also, so that she has not to take further, because only early age patient develop breast cancer like 35, 30, 40, then she has to take the years. 10 years, 55 years, 10 years, she has to take the hormonal therapy till her menopause. So we request the surgeon can go to oophorectomy. Similarly, orchidectomy in the prostate cancer. Prostate cancer is also hormone dependent. So either patient we have to do medical castration, or we ask the surgeon to do the surgical castration. If medical castration, then we have to give the GnRH analog or anti-GnRH therapy for the whole life to the prostate cancer patient, or simple orchidectomy as well, because the prostate cancer is the disease of the old age. If surgical castration being done, then there is no need for the GnRH analogs. So this about the surgery. So surgery is the most important part for the cancer treatment. Now come to the radiation therapy. The therapeutic radiation is the ionizing ejection of orbital electron when absorbed. So what ionizing radiation do? They cause break in DNA. What is cancer? Cancer is the abnormal uncontrolled growth of the cells. So cells proliferation, DNA is mandatory. It breaks in DNA and it damages the cancer cells. Radiation damage is augmented by the oxygen. So radiation for radiation therapy, certain hypoxic cells are more resistant. So if hemoglobin level is not good, anemic patient, so radiation therapy won't affect effectively. So patient should not be anemic. We have to give the blood transfusion first, then only radiation therapy will affect. Therapeutic radiation delivered in the three way: teletherapy, brachytherapy, and systemic therapy. Teletherapy is the most commonly used. It's a radiation generated at a distance. So brachytherapy, it's an encapsulated source of radiation implanted directly into or adjacent to the tumor tissue. Then systemic therapy, radionuclide administered intravenously, but targeted by some means to tumor site. Certain radiation sensitizers there like cisplatin, pyrimidine, hydroxyurea. Radiation therapy is also not toxicity free. Certain toxicities are there like fatigue, anorexia, nausea, vomiting. Now come to the chemotherapy. This is also one of the most important part, especially in the metastatic disease, and more than 50% solid cancer patients end up in the metastatic setting of it. Common myth for the chemotherapy: it's painful or always cause severe vomiting. It is given for a lifetime. It has a lot of side effects. It's always given intravenously. It's very costly. So many. But for last 15 years, there is no new chemotherapy invented. Now, what's focusing on the targeted therapy, immunotherapy, and anti-hormonal therapy or antibody drug conjugates. These are the least toxic therapies. So first come to the chemotherapy. What chemotherapy does? Chemotherapy break the DNA or RNA at a certain level so that cell can't proliferate. Cells, whatever in cancer cells, uncontrolled growth. Cells grow rapidly. Proliferation is rapidly, 1,000 lakh times more than the normal cells. So what chemotherapy do? Wherever there are more proliferation, more rapid proliferation, the chemotherapy acts there. But normal cells also proliferate. So at that also chemotherapy will affect that. That's why chemotherapy is having side effect, because apart from the tumor cells, it affect on the normal cells also. That's why chemotherapy are toxic. But cancer proliferations are exponentially very high than the normal cells. So it affects mostly on the tumor cells. There are certain examples of the cells you can see in this diagram. This purine, pyrimidine, they make the ribonucleotide, ribonucleotide to deoxyribonucleotide, deoxyribonucleotide to DNA, DNA to RNA, RNA to protein, and protein to. These are the mechanisms of the cell proliferation we used to read from childhood, I think, from biology only. So these are certain, these are chemotherapeutic agents at different levels it affect, and ultimately it affects the cells growth, cells proliferation. That is the mechanism of chemotherapy. Now come to the classification of anti-neoplastic drug, which is very complicated. Some chemotherapeutic agents are cell cycle specific, like anti-metabolites. These affect in the S phase. We know in DNA proliferation, G1, S, G2, M phase usually they are in cell cycle. So they usually target the cell cycle. Like anti-metabolites, they target on the S phase. Vincalculite, vincristine, vinblastine, these on M phase. Taxanes, paclitaxel, docetaxel, these also on M phase, metastatic phase. Then epidophylotoxin, G2RS, etoposide, teniposide. These are topoisomerase inhibitor. Bleomycin, they inhibit the G2M transition. Certain chemotherapeutic agents are non-cell cycle specific, like alkylating agent, platinum compound, cisplatin, carboplatin. Then camptothecins. These are also topoisomerase inhibitor, antibiotics, tumor antibiotics, except bleomycin, which is causing G2S transition, cancer cyclist. These are the commonly used anti-therapeutic agent, chemotherapeutic agent, which are being used in the medical oncology department. I'm not going in detail. Now coming to the targeted therapy. As I said, since last 15 years, no new chemotherapy has been invented. Only formulation of the chemotherapy invented so that toxicity can be reduced, but no invention of the new chemotherapy. Now world's focus is on the newer therapy, like targeted therapy. What targeted therapy do? You can see this trastuzumab. Trastuzumab target only in the HER2, HER1, HER3, HER4. These receptors are there on the cells, on the tumor cells. They target these tumor cells. So these are more focused, more precise. They are targeting on tumor cells. There is one ligand is there, HER1, HER2. So they will target that. Only cancer cell will kill, not other cells. Okay, like in proteasome is there. So even targeted therapy available for the proteasome also. Pertuzumab, trastuzumab, TDM1. These are all the targeted therapy. They focus on the certain target, certain ligand, certain substance, certain protein of the cell. That's for the tumor cells. So they are more specific with least toxicity. Chemotherapy you can't give for the 6 to 8 months, more than 6 to 8 months. But these targeted therapy, immunotherapy, newer therapy, you can give for the long time without cumulative toxicity. Like diabetes and hypertension, we can't cure. But patients are taking medicine and patients are doing well. These are chronic disease. So now focus is on to cancer, convert the cancer from fatal disease, lethal disease to chronic disease. So certain things should be there, certain medication should be there. So patient will take and it will go on, metastatic disease. Patient is taking medication, the patient is doing his work and his quality of life is good. So focus is to change the fatal disease into, convert the fatal disease into the chronic disease. So that's why these therapies are in the highlighted limelight in the world. Other targeted therapies are there. So many targeted therapies are there. Now come to the immunotherapy. What immunotherapy do? You can see this tumor cells, PD-L1 and T cells, PD-1. What PD-L1? PD-L1 is the ligand. What tumor cells are very smart. They act on the PD-1 of the T cell. PD-1 is immune checkpoint. So it bind to the PD-1. It means don't shoot. Tumor cells is giving signal the T cell, please don't shoot. So T cells means immune cells. It will not effective. These T cells are inhibited now. They won't act on the tumors. So because of this, T cell can't work. So now immunotherapy, what immunotherapy does? Anti-PD-1, nivolumab, pembrolizumab. So they inhibit the PD-1. They act on the PD-1 so that tumor cells now can't inhibit T cell. Tumor cell can't send signal to the T cell, don't shoot. Then T cell, if once the PD-1 or PD-L1 inhibited, then T cell start fighting, shooting, and it kills the tumor. So these are the immunotherapy cells. So immunotherapy, this is the function of the immunotherapy. So immunotherapy, in this era, immunotherapy, what's focusing on to develop newer and newer immunotherapy so that cancer treatment will be easier. So anti-PD-1 therapies are nivolumab, pembrolizumab, and anti-PD-L1, atezolizumab, durvalumab, and avelumab. Now hormonal therapy, hormone-directed therapy like glucocorticoid, certain lymphoma, they respond to the steroids, tamoxifen in the breast cancer. Now after immunotherapy, now new era is antibody conjugates. Actually, I'm saying this thing, showing this slide because everyone should know these are the game changer of the cancer. Cancer treatment is going to be changed very rapidly. And in a few years, we can see 80-90% cancers can be controlled easily. These are the new therapy. What is antibody conjugates? Adotrastuzumab. In this trastuzumab emtansine means targeted therapy is there trastuzumab, and the chemotherapeutic agent emtansine is a microtubule inhibitor. It's combined with the trastuzumab. So when we will give this therapy will go to the bind to the trastuzumab receptor, HER2 receptor, and inside that cell, emtansine, chemotherapeutic agent will release. So very precise treatment. So no toxicity for the chemotherapy and more targeted. So these are very effective. Some example I have mentioned, adotrastuzumab being used in breast cancer, brentuximab vedotin, it is Hodgkin lymphoma, and third one is trastuzumab deruxtecan. This is the game changer medicines, robust data. Even this thing, overall survival not reached by this therapy. So outcome of the cancer patient depend upon the stage of tumor, location of tumor, biology of tumor, and adequacy of treatment. Now I'm showing the slides how we measure the treatment outcome. This is the PET CT. This is in the downward slide. You can see very bright yellow. This is the cancer. This is FDG uptake in PET CT. Where the more proliferation of the cells, FDG will be more uptake. So there is a big tumor. When we give new adjuvant therapy, this tumor shrink to this. Second picture you can see it responded. Then surgery was done, and after surgery and following therapy, this is cured. There is no residual. Similarly, CNSopharynx, this is the PET scan image. This is the initial baseline. You can see, and after treatment, this is the. Now I'm coming to the certain some common malignancy we can see usually in the orthopedic common malignancy in India. So first we are coming to the breast cancer. This is the most common cancer in the women's. So first, whenever you will see the breast cancer, how you will diagnose, Pallavi ma'am has explained very well, abnormal lump. You can check the lump. Biopsy only can diagnose the diagnosis. But whenever patient usually come to us, first thing we used to do is staging. Without staging, you can't decide about the treatment. So staging is mandatory, and staging is very simple, but you have to do regularly. If you will do regularly, you will learn how to do stage. First, you have to see from the books. Stage every case. It's very easy. Anyone can do. There is no rocket science. You have to do certain tests, and you have to open your book. What is the stage? And after staging only, you can decide what is the treatment. Medical oncology treatment is like cancer treatment is like mathematics. Every protocol has been available everywhere. Guidelines are there. Just you have to confirm the diagnosis, proper workup, certain investigation, certain cancer you have to do, and staging. After staging, it's very simple to decide what treatment you have to give. Everything is available in the guidelines, in the books or in the apps. Stage 0 is ductal carcinoma in situ. We will diagnose only by the biopsy. Stage 1, tumor is less than 2 centimeters, no lymph node available. Stage 2, 2 to 5 centimeters. Stage 3, large tumor with fixed tumors, fixed metastatic nodes. And stage 4 is a distant metastasis. So that for this thing, whenever patient usually come to us, so we ask some certain investigation like mammography or ultrasonography. If patient is more than 40-year age, mammography. Otherwise, if it's a younger patient, we ask for the ultrasound. Because dense breast mammography won't react this thing, won't be very informative. So in young patients is there less than 40, we used to ask the ultrasound, the biopsy, and the CT scan, bone scan, or PET scan, whatever available at this time. So after these investigation, we used to do the staging. What's the stage of the patient? And breast cancer treatment depend on the immunohistochemistry. This is also immunohistochemistry. It's very simple immunohistochemistry available, I think, in every district hospital. ER, PR, HER2. We have to see these receptors, ER, PR receptor and HER2 receptor. So there are certain class subtypes are there. Luminal A, ER, PR positive, HER2 negative, Ki67 is low, best prognosis, hormone sensitive. Luminal B, bit aggressive because Ki67 is high, otherwise same. HER2 enriched is the HER2 is positive. I explained this trastuzumab, pertuzumab. These targeted therapies are being given for this cancer, HER2 enriched cancer. Prognosis poor but responsive to HER2 therapy. And triple negative, this is the most dangerous. Triple negative means ER, PR, you can't give hormonal therapy. HER2, you can't give targeted therapy. You are totally dependent on the chemotherapy. Triple negative breast cancer. So these are most aggressive, basal accept type, and certain mutations are there, common BRCA2. Younger age group, this is common triple negative. In family history is there, triple negative is more common. Now come to the treatment by the stage of the cancer. First you have to do staging, then you will decide what treatment you have to do. Early stage cancer, stage 1, 2, primary treatment is surgery, as I told you. Surgery can be breast conserving surgery or mastectomy you have to. After surgery, what adjuvant therapy you have to give? It will be decided by the hormonal status or risk factor. Surgery, common chemotherapy being used are taxanes, anthracycline, and cyclophosphamide. These chemotherapies are there, and it can be given at every center. Simple medications are there. You have to dilute in the NS or 5% dextrose and give it the solution. Once you start giving, it's not a rocket science, it's simple. Then hormonal therapy, if ER, PR is positive, you have to give hormonal therapy. Chemotherapy is high risk feature triple negative, then you have to give chemotherapy. Radiotherapy is required if breast conservation surgery is done. Whatever stage you have to give radiotherapy to reduce the recurrence. Or if patient is having tumor more than 5 centimeter or lymph nodes are positive, then also, or margins are positive, then also radiotherapy is needed. Then HER2 targeted therapy, if HER2 is positive, example trastuzumab, pertuzumab, these are the therapy which are being given in the HER2 new positive therapy. So in breast cancer, staging you have to do, staging is mandatory. Second thing, ISE, immunohistochemistry, ER, PR, HER2 new. Before starting treatment for any breast cancer, you must know this classification subtype of the breast cancer, because if hormone positive, you have to give hormonal therapy after every treatment of 5 to 10 years. Now come to the locally advanced cancer stage 3. In this cancer, initially surgeon used to send to us, it is not possible to remove the whole tumor, then please give some neoadjuvant therapy. So we used to give neoadjuvant therapy. Neoadjuvant therapy we decide as per the type of the tumor, whether HER2 is positive, HER2 negative. Different neoadjuvant protocols are there. So as per protocol, we have to give chemotherapy. Then patient will go for the surgery. And I have mentioned previously, after surgery, we will see the response, whether pathological complete remission is there or not. Then we will decide the treatment. Then post-operative therapy and radiotherapy to chest wall and regional lymph node. Because locally advanced disease, you have to give the radiotherapy and adjuvant hormone therapy, PR positive for 5 to 10 years. You have to give the hormonal therapy also, because these are slow growing tumor and late recurrences are common. If patient arrives in the metastatic disease, then metastatic disease also we have to treat in the same manner. If patient is hormone positive, we will give simple hormonal therapy, oral therapy. No need to give chemotherapy. Chemotherapy, only certain indications are there, even in metastatic disease. If patient is triple negative, then treatment is chemotherapy. If it is HER2 positive, then targeted therapy along with the chemotherapy. Now come to the cervical cancer. This is also very common cancer. Staging. For the staging, stage 1, cancer confined to the cervix. Stage 2, beyond cervix, but not the pelvic wall or lower side of the vagina. Stage 3 involves It involves the pelvic wall, lower vagina, cause hydronephrosis, and stage 4, beyond the pelvis. So you have to do the staging. After doing investigation, clinical workup, you have to stage every cancer patient, cervical cancer patient. So treatment also differ in the every stage. In early stage, only conization or simple hysterectomy is needed. As we will go for 1A2 or 1B1, radical hysterectomy along with the lymphadenectomy should be done. Then further, when surgery stage 2 or stage 3C, then chemoradiation is also very effective therapy. No need for the surgery. Chemoradiation means chemotherapy along with the radiotherapy. Concurrent CCRT, concurrent chemoradiation therapy. CCRT we used to give to the middle stage 2, stage 3. Even stage 4A we can try over the definitive chemoradiation to cure the patient. Generally stage 4 are metastatic, they are not curable, but we can try. And stage 4B is palliative. Palliative means you have to palliate the symptom like chemotherapy, radiotherapy plus minus, and supportive and palliative care. Now come to the common cancer, oral squamous cell cancer. This is also one of the most common cancer, and it's very difficult to treat and very painful cancer for the patient. Patient ka muh nahi khulta, patient can't open his mouth. Very pity to see these type of patients. Patient can't eat. Very difficult to treat. So whenever oral squamous cell cancer patient comes, we have to do staging. Staging, TNM staging we used to do for F tumor. T1 is less than 2, T2 more than 2 to 4 centimeter, T3 more than 4 centimeter. If in investigation it is invasion of the bone like MRI, CT scan or carotid involvement. Similarly, by the investigation, you have to do the nodal staging, whether it is N0, N1, N2 or metastatic, not metastatic. After that, you will decide the staging. It's very simple. On books, it's looking very difficult. But when you will start yourself, after 1 week, after 5 to 6 patients, you can be confident in doing staging. And after once you did staging, then treatment is like a roadmap. You can open the book, what to do in this, what treatment. It's like mathematics. So stage 1 is T1 and T2, stage 1 is stage 2, stage 2, stage 4. These are the staging. You have to do staging. Then the further treatment depends on the stage. Early oral cancer prognosis is very good. For oral cancer, treatment is surgery and surgery. Surgery is the most important. If surgery being done in time and in initial stage and complete surgery, then only chance of cure. If surgery is not possible or after surgery recurrence, if recurrence after surgery, then again you have to do surgery if you want to cure. Otherwise, it's very difficult to cure, even for the localized disease, if recurrence after surgery. So surgical excision with adequate margin more than 1 centimeter, neck dissection, because metastasis to the lymph node. Optional for the stage 1, otherwise in a higher stage, you have to do neck dissection. Then adjuvant radiotherapy not usually required unless there is a positive margin or perineural invasion or lymphovascular invasion or DOI, depth of invasion in more than 4 millimeter, then only adjuvant radiotherapy needed. Otherwise, so initial early stage, stage 1, stage 2 outcomes are very good, high cure rate with surgery alone. Now come to the advanced and metastatic disease, stage 3, stage 4. These are difficult to treat. Locally advanced disease, no distant meds, then surgery plus neck dissection. Primary neck plus cervical lymph node have to be removed. Then post-operative radiotherapy, PORT or chemoradiation, whether it is needed or not, if high risk feature like ENA, extranodal extension, or positive margins are there, then post-operative, even after the good surgery, you have to give the radiotherapy. If patient is having non-resectable tumor but localized, then also you have to give him fair chance to cure. Then definitely chemoradiation is the modality. Radiotherapy is also local therapy. Go hit the tumor and surrounding area, it will kill by the radiation itself. And chemotherapy is also being given along with the radiation, the chemoradiation. So more chances of the cure. Metastatic disease stage 4BC, if metastasized, then your patient is not going to be cured. You have to give the palliative treatment. Palliative chemotherapy, you will not go in the very high dose what we are giving in the curative setting. So because you have to look for the quality of life also, or immunotherapy. Now role of immunotherapy is being increased. Certain biomarkers are there, like PD-L1 is high, then we will add the immunotherapy. If patient responds to immunotherapy, because chemotherapy, as I said, nobody can tolerate after a few months. So but chemotherapy's peculiarity is it acts very fast. In rapidly growing tumor, when chemotherapy hits, then tumor response to the chemotherapy, it will shrink very fast. So immunotherapy acts very fast, but immunotherapy and targeted therapy, they act slowly, gradually. So if symptom reliefs are there or tumor size, you have to reduce very fast, or you have to stop the metastasis in rapidly growing tumor, then chemotherapy is very effective. Along with the immunotherapy, and after a certain time, we used to stop the chemotherapy, but immunotherapy will continue till the progression for a long time, till patient responses. Chemotherapy agents like cisplatin, 5-FU, and cetuximab. Cetuximab is EGFR inhibitors. These EGFR receptors are there in the head and neck tumor. So cetuximab is a targeted therapy. So that also can be given for the long time till progression. And checkpoint inhibitor is immunotherapy like pembrolizumab, nivolumab. These are indicated in this type of cancer. And supportive treatment. This is also very important. Supportive care. This is one of the most important part of the treatment. Pain management. Cancer pains are very severe. Nutrition, oral cancer, how we eat. So nutrition, you have to give supplementation by the NGTO, pack, whatever modality, but you have to give the nutrition. Protect the airway, psychosocial support, and multidisciplinary care is essential. Now come to the lung cancer. Lung cancer is also very increasing. Previously, it was the conclusion that smokers only having the lung cancer, but now not. So many patients usually come in our PD. Out of 10, 1 or 2 patients are there which are non-smokers. They never smoke in their lifetime, but they develop some lung cancer. Lung cancer are the 2 types, non-small cell and small cell lung cancer. So non-small cell lung cancers are also adenocarcinoma, squamous carcinoma. So you have to stage the disease, whether it is localized, initial stage 1 or stage 2 localized, stage 3 locally advanced, stage 4 metastasize to other So initially stage, every cancer can be curable, but unfortunately, initially stage patients are only 5%, 10% patient usually arrive in an initial stage of the lung cancer. Otherwise, they usually come in the metastatic because initially they would have, in India, tuberculosis is so common. So many patients are on anti-tuberculosis therapy for the months, 9 months, 6 months, not responded. Then only after workup, biopsy done and diagnosed as a lung cancer. So delayed diagnosis is the very important cause for the poor prognosis. Now come to the small cell. Small cell lung cancer usually occur only in the smoker, and this is the one of the most dangerous tumor of the body, very rapidly progressing. Proliferative index is highest of the small cell lung cancer in solid tumors. These are also classified staged as in the limited stage and extensive stage. If it is limited, confined to one hemithorax, treatable with a single radiation field, it is limited stage. Extensive stage, if it is beyond the hemithorax, include the distant beds. So this is very dangerous, very aggressive, very lethal tumor, but it responds very well to the chemotherapy because proliferative index is so high. This proliferate very rapidly, and the tumor which proliferate rapidly, chemotherapy will affect more, because they have the cell cycle based on DNA manufacturing the alkylating agent. So they will act very rapidly there. Imaging modality, CT thorax, PET CT, MRI brain, and biopsy. These are the imaging modality for the diagnosis and staging of the cancer. Now come to the treatment. Initial stage surgery along chemotherapy may or may not be given, depends. Stage 3 chemotherapy followed by the radiation therapy. Stage 3A3 because very difficult to resect. Otherwise surgery is always better because you have removed the tumor. But stage 3A still surgery is possible, but 3B it's very difficult. So in that definitive chemoradiation, after that immunotherapy. I said that in last few years only immunotherapy, new immunotherapy diagnosed. So now immunotherapy durvalumab is being given for the 1 or 2 years to decrease the chances of recurrence. If it is stage 4, then only systemic therapy like chemotherapy or targeted immunotherapy. Similarly, in the limited stage of the small cell lung cancer, chemotherapy plus radiation therapy. Once it is extensive, then there is no role of the definitive radiation therapy. Then you have to do the chemotherapy along with the immunotherapy. If patient is affordable, you have to do the immunotherapy because prognosis is very poor for the small cell lung cancer. Now I said because nowadays so many patients usually come without any smoking history, but they are having lung cancer. Certain mutations are there in the body. In 2002 or 2003, whole genome was sequenced. What happened to that? Whole genome was sequenced. Then genome of the cancer patient were compared with the normal genome, reference genome. So certain mutations were detected. So in these patients, certain mutations are there which are culprit for the cancer, like EGFR mutation, ALK mutation, ROS1, so on. Thousands of mutations are there. But for these mutations, targeted therapy has been invented. So this mutation is the culprit for the cancer, and target therapy, which specifically, precisely targeted on this target, kills this target cells. So these are very effective therapy, least toxic therapy. Like in EGFR mutation is there, this is the most common mutations in Indian patients, in Asian patients. So targeted therapies are available are osimertinib, erlotinib, afatinib, ALK. If ALK mutations are there, then alectinib, lorlatinib, brigatinib, ROS1, crizotinib, entectinib. These targeted therapies are available. So if lung cancer patients is here who is having this target, so we will give this target therapy. We will not give chemotherapy unless indicated. So these are very effective, and you can't believe I have patients who are alive for last 10 years. They are taking 9 years. Sorry, they are taking simple 1 tablet daily. No one can say these are the cancer patients. Previously, before invention of this, before discovery of these, usually they used to be given chemotherapy, and 1 year, maximum 1.5 year, 2 year patient used to die. But because of these therapy, their last 10 year patients are alive and they are taking only single oral tablet, no IV medication, and you can't say these are the cancer patient. Now come to the immunotherapy in non-small cell lung cancer, small cell lung cancer. If PD-L1, I explained previously, PD-L1 is more than 550% in any lung cancer patient. So what we will do, we will give only immunotherapy, even in metastatic setting, no chemotherapy, only immunotherapy will affect, and patient usually used to do for the years, patient do well on immunotherapy, PD-L1 more than 50%. If less than 50%, then combination of chemotherapy along with the immunotherapy. And after certain cycles of the chemotherapy, after 4 to 6 month chemotherapy usually stop. Immunotherapy will continue till the progression, till infinite time, immunotherapy will continue. In small cell lung cancer also immunotherapy is there, but role of immunotherapy is not as good as the other cancer in small cancer, but these are indicated, atezolizumab, durvalumab indicated in the small cell lung cancer, and I told this is one of the most dangerous cancer in the body. Just this is a graph showing you the importance of this targeted therapy. You can see the osimertinib is the second generation TKI for the EGFR mutation, and then comparatively EGFR TKI first line. You can see the osimertinib median overall survival is 38.6 months, more than 3 years. Median means if 100 patients are there, 50 patients are alive till 38 months, and we have patients for more than 9 years. They are doing it. 9 years, 8 years. This is the graph. It's still going on, not coming down towards the end. Similarly, ALK mutated cancer. You can see alectinib is the one drug. 60% patient who started alectinib in the cancer patient, lung cancer patient, who have ALK mutation, they are alive at the 5 years. So for the lung cancer patient, every patient should go for the NGS testing. If there is a mutation, the patient will be very lucky. There is no need for chemotherapy. They will improve only on the target therapy. Now come to the survival, the 5-year survival in the cancer cervix. 80 to 90% of women in the stage 1 cancer, 50 to 65% stage 2, 25 to 35% stage 3, and 15% on over the stage 4 cancer. So survival depends upon the stage, early stage cure, metastatic stage, controlled and symptom relief. In metastatic disease, breast cancer survival more than 5 years because of the hormonal therapy, targeted therapy. Lung cancer more than 2 years because of the immunotherapy, targeted therapy. Kidney cancer I am not mentioned here because it's not as common as others. Kidney cancer also no chemotherapy is needed, only immunotherapy, targeted therapy, and survival is more than 5 years in metastatic setting, and ovarian cancer also more than 5 years. So final conclusion, cancer is treatable, often curable, early detection improves survival, multimodality treatment is standard of care, supportive and palliative care is integral and require a multidisciplinary. Thank you.
Thank you
Thank
so much, sir, for such a
very nice presentation. And I think though we are running short of time, but we should take 1 or 2 questions at least.
Yeah, please.
So one question I can see in the chat box is regarding the breast swelling, if fibroadenoma, which is unilateral, size changes with the menstrual cycle, is predisposed to malignancy. This is the question.
No, fibroadenoma is not predisposing to the malignancy. For the cosmetic purpose only, surgeon wants it to treat or to. If like some metaplasia, apocrine metaplasia along with the fibroadenoma, but with the atypical metaplasia, atypical proliferation, then also it can cause. Otherwise, fibroadenoma is totally benign. It won't convert to that.
So another question is, which is the cost-effective therapy among all these?
Cost-effective therapy. Actually, cost-effective therapy, definitely it's the oldest therapy is the cost-effective therapy. I want to highlight in 2001 targeted therapy, imatinib was discovered for the CML patient, previously CML patient, bone marrow transplant and intervention. Imatinib, that time it cost around, I think, 5 to 6 lakhs per month or something per month. But now in every government hospital, 2,000, 3,000 or even less than 2,000 patients are getting free. So it depends in which era it was discovered. Chemotherapy usually used to be very costly in initial days. Now it's cheaper, 500, 600. So these therapies are new therapies. Patency rules are there. Before 10 years, you can't prepare the biosimilars. So as the time go, every therapy will be the cheaper one day. And after 5 years, I think in government hospital, immunotherapy will be available free of cost. because patent will be, I think, breached after 1 or 2 years.
So another question is, if there is an armpit swelling, will it also be considered as predisposing to malignancy?
Armpit swelling, yeah, depends on the what's the age and sex. If it is female is there, armpit swelling is there, then and the middle age is there or higher age, then breast cancer could be there, lymphoma could be there. So nothing. They have to do self-breast examination or go to the one's physician. Surgeon, he will check. Because cancer lump is usually hard, like a stone. It's not a simple lump. So by clinical examination only, it will be detected it's not a cancer or not. It's very simple. Cancer swelling like stone, very hard.
Right. Another question, though it was discussed in the previous lecture, pan or betel nut without the tobacco, is it also predisposing to malignancy?
Yes.
It was very clearly categorically told by Dr. Pallavi.
Yeah,
Even
it was
if there
category
is
two.
no tobacco, palm leaves as well as betel nuts, supari, they are equally, they may be carcinogens. Another question was regarding the vaccination. So the question is whether females should be vaccinated for HPV even after 14 years. Yes, of course. But I would like to put some light on that.
Even to 45 years you can give.
To 45 years. So though the government has not yet finalized the policy.
That Pallavi ma'am explained this thing as well. She highlighted this
Absolutely.
point.
So up to, as far as things are going on, so up to 45 years we recommend, but even after that, if beneficiary wants, then they don't refuse.
Yeah,
But in
definitely.
boys, in India, they are not recommending beyond 26 years. That is my understanding. You can correct me if I am not correct.
Correct. Yeah, correct.
So thank you so much, Dr. Kalra. If any further questions, we'll ask you later.
Okay.
And
Thank you
so
so much.
with the due permission of NHSRC team, can we proceed to the third session?
Yes, ma'am. Yes, ma'am.
Okay. So is my screen visible? I've already shared that.
Yes, ma'am. Your screen is clearly visible.
In my screen, there are multiple windows are coming, so I'm not sure whether it's coming on main screen also.
Ma'am, your screen is clearly visible.
Okay, so I will start with.
But there are boxes. There are boxes that are appearing.
Yeah, they were not. So I think I'll go back and reshare the screen.
Yes, ma'am. Yes, ma'am.
Meanwhile, introduce, madam.
Okay, ma'am. Meanwhile, I'll just introduce you to all our participants.
I
So,
think most of them are aware. I will just try to reshare my.
yes, ma'am. So, Dr. Vandana Bagga, ma'am, is a former vice chairperson, SHS Delhi, State Program Officer for Quality Assurance and Patient Safety, DSHM. And she is a medical graduate with post-graduation in anesthesiology from MAMC, MBA in hospital administration from FMS Delhi. She's also a gold medalist, PGD in healthcare quality management from TIS Mumbai, PG in quality management and accreditation from AHA Noida, PGDCM from NIHFW, gold medalist, and CHCWM from IGNOU. She has more than 38 years of extensive clinical and administrative experience, and she has worked across administrative works in GNCTD hospitals. And she's also a recipient of the prestigious Delhi State Award in the year 2011 to 12, with a WHO fellowship and multiple awards from IMA and DMA.
I think we can cut off after that because already everybody is getting impatient because we are running late. So I will make it very short and crisp. And basically, the reason for this presentation is that we want to learn so many things, and then we suddenly feel, "Hum kya kare? Hamare paas bahut sare constraints hain. How do we do it?" So the main thing that comes across after hearing both the previous speakers is, though it is a very difficult disease, it's like a stigma in the society, and there is lots of fear. Everything is there. But what can we contribute to contain the disease? And the whole thing boils down to a collective approach, a teamwork approach, which starts from the community, from the beneficiary, awareness among the beneficiary, to the grassroots level workers, which include upwards with the referral system, with the CHOs, the medical officers, followed by district hospitals and tertiary care center. Doesn't stop there. After the treatment is done, again, we have to so cancer is one disease which actually does not affect the patient only, it affects the family. It's a family disease. So it's very important that all of us should be aware what all contribution we can make in whatever position we are there right now. And if we are facing certain challenges, how do we overcome those challenges? So I am going to take you through the challenges that I have been seeing and anticipating, and how to overcome those. And all of these challenges, each one of these have same components: the community component, the grassroots level, the primary healthcare, the secondary healthcare, as well as the tertiary healthcare. So, like we know that initially National Cancer Control Program was launched in 1975. For more than 3 decades, nothing much could be achieved. Though we were having cancer clinics in the hospitals, we were trying to provide the opportunistic screening. That was also not done to a large extent because of the stigma, because people would not like to come. There was lesser index of suspicion. So the uh, the outcome was not very motivating. In 2010, it was integrated into National Program for Control of Cancer, Diabetes, and other disease. But later on, it was again very recently, it has again been named as a National Program for Non-Communicable Disease, and cancer is one of the important component of that, which we are discussing. So in this program, from the opportunistic screening that we were initially planning, the policy was shifted to population-based screening, for the very fact that earlier the disease is detected, more are the chances of cure and recovery, because in the very recent second last slide only, Dr. Kaushal has said that cancer has now become not only treatable, it has been labeled as curable also in many of the cases. So also the treatment is now, involvement of primary healthcare is very important in the implementation of the cancer control component of non-communicable disease program. Earlier कैंसर का नाम सुन के सीधा बड़े अस्पताल जाना है, टर्शरी केयर सेंटर में जाना है. It's not like that now. And the roles of each and every person have been very categorically defined. And in fact, I have requested NHSRC team that whatever material literature is available, the guidelines for the non-communicable disease implementation, as well as the guidelines for various levels of workers, including medical officers, ANMs, ASHAs, soft copies will also be shared by all the participants who attempt pre-test as well as post-test. So that will again it will be a part of capacity building of our teams up to the last mile, up to the frontline workers, which will be the very important component of this program. So if we see the challenges, there are various types of challenges. मोटा 8 तरह की हमको प्रॉब्लम पता लगती है. ह्यूमन रिसोर्स, मैन पावर नहीं है, क्या करें, इंफ्रास्ट्रक्चर नहीं है, सामान नहीं है, सामान आ जाता है लेकिन खत्म हो जाता है, तो उसके अंदर गैप एरिया आ जाता है जब हमें बीच में कुछ पीरियड होता है जब सामान नहीं मिलता है. हमें HMIS सिस्टम नहीं है, हम IT टूल्स यूज नहीं कर पा रहे, either there is not good connectivity or people are not trained for that. मैनुअल रिकॉर्ड्स आर बीइंग मेंटेन्ड, बट वो कंटिन्यूटी ऑफ ट्रीटमेंट उससे नहीं हो पा रहा, बिकॉज हम उसको प्रॉपरली रिकॉर्ड मेंटेन नहीं कर पा रहे. देयर इज डिसकंटिन्यूटी ऑफ द रिकॉर्ड. सो अगेन इट रिजल्ट्स इन इनकम्प्लीट ट्रीटमेंट. इनकम्प्लीट ट्रीटमेंट मीन्स पुअरर आउटकम. अगेन फाइनेंस एंड गवर्नेंस. सो डॉक्टर कोतवाल ने अपने इंट्रोडक्टरी स्पीच में हमको बताया था कि अभी Dedicated funds have been given for that. तो इम्पोर्टेंट इसमें हम लोग का रोल कहाँ पे आ जाता है, जब हम लोग अपना PIP बनाते हैं, उसके अंदर हमने प्रॉपरली फंड मांगा के नहीं। हमारा इस प्रोग्राम के अंदर गवर्नमेंट हैज गिवन द डेडिकेटेड सफिशिएंट फंड फॉर ऑल द एक्टिविटीज, बट ऑल द एक्टिविटीज हैव बीन कैटेगोरिकली डिफाइंड, क्लियरली डिफाइंड, किस एक्टिविटी में कितना आपने खर्चा करना है, कितना इंफ्रास्ट्रक्चर के लिए है, कितना दवाई के लिए है, कितना IAC के लिए है, कितना कम्युनिटी इन्वॉल्वमेंट के लिए है, कितना होम विजिट्स के लिए है, रेफरल के लिए, वो सब उसमें कैटेगोरिकली डिफाइंड है। 60% fund of that comes from the central government and 40% comes from the state government. In addition to these, there are additional schemes in individual states as well. And these are the state specific because health is a state subject. So those will be in addition to NP-NCD program, in which we are discussing the cancer treatment component only right now. Now, community awareness and engagement, it starts with the community. मुझे अगर index of suspicion ही नहीं है, I will not even come to show. There are various other issues, service delivery issues, which we'll tackle one by one. So service delivery में क्या हो जाता है, हमारा आज की डेट में less than 20% eligible population is being covered for the screening. So we need to do more of the screening activities. We need to do more outreach activities. We need to make it more acceptable to the people. नुक्कड़ नाटक कर सकते हैं, उसमें हमें अपॉर्चुनिटी ढूंढनी है। जब हमारे दूसरे कोई प्लान्स चल रहे होते हैं, उस टाइम पर जब आशा दीदी सब लोगों के घरों में जाती हैं, दे कैन स्प्रेड दिस इंफॉर्मेशन एज वेल। दे आर फिलिंग द सीबैक फॉर्म्स, उसके लिए अलग से एक्टिविटी नहीं करनी पड़ रही है हमको। सीबैक फॉर्म के अंदर ही 2-4 क्वेश्चंस, 5 क्वेश्चंस ही हैं जो हमें अर्ली स्क्रीनिंग फॉर कैंसर दिखा देते हैं। इसी तरह से रेफरल एंड फॉलोअप, हर पेशेंट को अगर हमने टर्शियरी केयर सेंटर में भेज दिया, दे विल बी सो ओवरलोडेड दैट पेशेंट्स हु एक्चुअली रिक्वायर द अर्जेंट ट्रीटमेंट, उनको बहुत टाइम के बाद की डेट्स मिलती हैं। So it is very important that whatever can be handled at a lower level must be handled, but we must be aware when to refer the patient, when it becomes a serious symptom, and when it has to be taken care by the higher level. So urban rural disparity तो है, rural areas में infrastructure कम है. We in Delhi are a privileged community because Delhi is 95% urban. But in other states, rural areas are there. There are, for vast stretches, there is only one maybe the health facility because population is widely dispersed. उस टाइम पर हमारे community health workers का रोल बहुत ज़्यादा important हो जाता है as far as information, education, communication and screening is involved. सिर्फ information देने से नहीं होता, हमको इसको डिस्टिग्मेटाइज करना है, स्टिग्मा हटाना है. किसी को भी घर में कैंसर है नहीं पता लगना चाहिए, क्योंकि उसकी बहुत सारी इम्प्लीकेशंस हो सकती हैं. बच्चे की शादी नहीं होगी, कम्युनिटी से उसको आउटकास्ट कर दिया जाने का रिस्क रहेगा, लोगों को लगेगा कि शायद इन्फेक्शियस है, सोशल बाइकआउट होने का रिस्क होगा. ये सारे मिथ्स हटाना हम लोगों की जिम्मेवारी है एट ईच एंड एवरी अपॉर्चुनिटी. ईच एंड एवरी अपॉर्चुनिटी वैक्सीनेशन के लिए हम जाते हैं, हमें उनके पेरेंट्स को बताना जरूरी है कि there are other vaccination modalities available. Very shortly, HPV vaccination will be coming up because government has already initiated the training TOT programs for that. So, लेकिन अगर मालूम ही नहीं है, so सबसे पहला सवाल आएगा, मेरी लड़की 9 साल की को मैं क्यों लगाऊं? She is not sexually active. जब उसकी शादी होगी हम तो तब वैक्सीन लगवा देंगे उसको. लेकिन हमारा काम है उनको ये बताना कि 9 साल की उम्र में वैक्सीन की जितनी इफेक्टिवनेस है वो 25 साल में नहीं आएगी. अगर उसको 9 साल की उम्र में वैक्सीन लग गई, वो पूरी जिंदगी उससे मुक्त रह सकती है. 25 साल की उम्र में लगेगी, अगर वैक्सीन लगेगी तो उसका बीमारी से बचाव की प्रोबेबिलिटी कम हो जाएगी. तो इस तरह के क्वेश्चनर्स हमें अपने पास रेडी रखने चाहिए, जो पॉपुलेशन इंटरेक्शन में जो उनकी क्वेरीज आती हैं, वो क्वेरीज के आंसर ना सिर्फ बना के हमें देने हैं, हमें उसको शेयर करना है अपने पीयर ग्रुप से. बिकॉज एवरीबडी मे नॉट आस्क यू, बट दे मस्ट बी हैविंग दोज क्वेरीज इन देयर माइंड. So whenever we get some query, it is very important that we have to share it with our peer group also. अगर ये सारा कुछ होता है, हमने जैसे बात की थी, कंटिन्यूटी ऑफ केयर इज वेरी इंपॉर्टेंट। अगर हमारा HMIS सिस्टम या हमारा इवन पेपर रिकॉर्ड भी कंप्लीट होता है तो उससे कंटिन्यूटी ऑफ केयर होता है। और अब तो बहुत आसान हो गया है बिकॉज देयर आर सो मेनी पोर्टल्स विच आर वेरी यूजर फ्रेंडली एंड in fact there are some state specific portals. I have visited various states and I have seen that they have simply installed notebooks or tabs in their wards, in their OPDs, everywhere, and everybody knows how to use the thing to upload the data that they have, upload the records of the patients. I have seen paperless primary health centers also. So they are very easy to operate apps. So that has to be taken care. Human resource challenge तो है, लेकिन उसको क्या हम ऑप्टिमाइज कर रहे हैं? हमारे पास अगर 10 की जगह 7 लोग अवेलेबल हैं, उसमें से सिर्फ 3 ट्रेन हैं, तो एटलीस्ट हम बाकी 4 को इतना ट्रेन कर सकते हैं कि दे शुड बी एबल टू हेल्प अस। बट दैट डज नॉट मीन नॉट स्टैंडिंग कि हमें फुल मैन पावर नहीं चाहिए। So again, going back to the planning part, government in their policy have already kept the provision for sufficient fund to be provided to manpower, or manpower requirement has already been rationalized in the guideline that has been prepared by Ministry of Health and Family Welfare regarding the NCD national program. We can see turnover now. This becomes a very multifactorial aspect. And multi-pronged approach has to be used for this. So हमारा एक दिल्ली में हॉस्पिटल थोड़ा आउटरीच पे था और उसमें हमें कभी भी एनेस्थीसिया, अभी हमें इंट्रोडक्शन में बताया गया कि आई एम एन एनेस्थेटिस्ट, तो उसमें ये देखा जाता था कि मोस्टली हॉस्पिटल्स में एनेस्थीसिया में रेजिडेंट डॉक्टर्स नहीं मिलते थे, बहुत जल्दी छोड़ के चले जाते थे। पर उस आउटरीच हॉस्पिटल में हमेशा 4 वैकेंसी है तो फिल्ड रहती थी। उनके HOD से पूछा आप ऐसा क्या करते हो इनके लिए? तो उन्होंने बोला हम इनको बहुत प्यार से संभाल के रखते हैं, बिल्कुल अपने खजाने की तरह। सो यू हैव टू बी वेरी एम्पैथेटिक टुवर्ड्स योर स्टाफ। उनको क्या दिक्कत आ रही है उसमें से क्या आप हैंडल कर सकते हैं। सो दैट इज इम्पोर्टेंट टू रिड्यूस द एट्रिशन रेट। अगर ट्रेनिंग कंप्लीट नहीं होती तो भी बिकॉज ऑफ लैक ऑफ कॉन्फिडेंस पीपल डोंट फील लाइक स्टेइंग। So this is also another part. छोटी छोटी चीज है, जैसे हमने बोला था, अभी हम बात कर रहे थे VIA का या विली का, कि दे आर वेरी सिंपल टेस्ट, बट अगर पता है कैसे करना है तो उसको करने में कॉन्फिडेंस आएगा, पीपल वुड नॉट लाइक टू लीव। लेकिन अगर नहीं पता है तो स्टाफ माइट लूज इंटरेस्ट। अगेन अवेलेबिलिटी ऑफ रिसोर्सेज अगेन बिकम्स अ पॉइंट। तो अगर है, और हम सप्लाई चेन की भी बात करते हैं, तो टाइमली हमें उसकी डिमांड डालना इज वेरी इंपॉर्टेंट, बिकॉज वी नो नॉर्मली कहीं पर 2 महीना लगता होगा, पर मेरी फैसिलिटी में तो सामान आने में 4 महीना लगता है। तो मुझे कम से कम 4 महीना पहले उतना मार्जिन लेकर उसका प्रोसेस स्टार्ट कर देना चाहिए प्रोक्योरमेंट का। We will not go into the micro details of all these aspects. I am just touching all these things which are, these factors are applicable at every level, community level, primary, secondary, tertiary. At every level, these are the common factors which come up as challenges. Again, infrastructure, diagnostic challenges. इसके लिए अब बहुत क्लियर कट गाइडलाइन आ गई है कि प्राइमरी हेल्थ सेंटर पे क्या क्या आपके डायग्नोस्टिक्स अवेलेबल होंगे, सेकेंडरी पे क्या होंगे, टर्शरी पे क्या होंगे। हर पेशेंट को जरूरत नहीं पड़ेगी MRI कराने की, हर पेशेंट को जरूरत नहीं पड़ेगी आगे बाकी टेस्ट कराने की, अगर वो स्क्रीनिंग में आपके लेवल पे निकल जाए। हाँ, लेकिन अगर कहीं पर भी डाउट होता है तो मस्ट कंसल्ट द हायर रेफरल सेंटर। सो अनदर थिंग इज दैट डे केयर। अभी इसमें भी मॉर्निंग में हमें डॉक्टर कोतवाल ने बताया था कि इसमें भी गवर्नमेंट ने जो पॉलिसी स्टार्ट की है, सो देयर आर टर्शरी सेंटर्स, जैसे दिल्ली में LNH लोकनायक हॉस्पिटल हैज बीन डेजिग्नेटेड अ टर्शरी कैंसर केयर सेंटर, और उसके अलावा 4 सेंटर्स हैं जो डे केयर कैंसर केयर सेंटर्स के रूप में डेजिग्नेट कर दिए गए हैं, 4 डिस्ट्रिक्ट हॉस्पिटल्स। तो इसी तरह हर स्टेट में डेजिग्नेटेड डे केयर कैंसर सेंटर्स बनाए जा रहे हैं, जिसके अंदर हमको बहुत ज्यादा एडिशनल रिसोर्सेज नहीं चाहिए, लेकिन क्या क्या चाहिए वो ऑलरेडी एनेक्शन में अवेलेबल हैं, जो हमारी गाइडलाइंस हैं। of NP-NCD program implementation. सप्लाई चेन हमने ऑलरेडी बात कर लिया है कि सप्लाई चेन में हमको हमेशा ध्यान रखना है फैक्टर्स विच आर नॉर्मल फैक्टर्स, फैक्टर्स विच आर बियॉन्ड नॉर्मल फैक्टर्स। कभी कहीं पर बाढ़ आ गई तो सप्लाई चेन डेफिनेटली अफेक्ट होगी। कहीं पर रूटीन टाइम आपका डिफिकल्ट टेरेन है तो डेफिनेटली सप्लाई चेन दिल्ली में जितना जल्दी सामान आता है और अरुणाचल प्रदेश में आता है तो देयर विल बी अ डिफरेंस। उसका मार्जिन लेकर ही हमको अपना सिस्टम बनाना है, एसओपी बनाना है, टाइमली उसको हमको इनिशिएट करना है प्रोसेस ऑफ प्रोक्योरमेंट ऑफ। सिमिलरली देयर आर लॉट्स ऑफ एप्स, हम अभी उसके टाइम बिकॉज ऑफ द कंस्ट्रेंट ऑफ टाइम आई कैन नॉट गो इनटू द डिटेल, बट अगर हम टाइमली और रियल टाइम में अगर अपना रिकॉर्ड मेंटेन करते हैं तो जो डेटा अवेलेबल होता है उसकी एक्यूरेसी डिपेंड करता है कि हाउ द पॉलिसी मेकर्स डिसाइड अबाउट द डिस्ट्रीब्यूशन ऑफ रिसोर्सेज, द अवेलेबिलिटी ऑफ फंड्स, द allocation of funds and allocation of various other resources. So it is our responsibility even from the lowest primary healthcare level that we should be providing the actual, factual and correct data. So this is very important. Financial, we have already talked about the dedicated fund that has been allocated. हम हमेशा बोलते हैं नोडल ऑफिसर्स बहुत ओवरबर्डन रहते हैं। ओवरबर्डन इसलिए रहते हैं बिकॉज सब कुछ एक जन के ऊपर हम नहीं डाल सकते। वी हैव टू वर्क एज अ टीम। सो टीम मीन्स टुगेदर एवरीवन अचीव्स मोर। हमने बात किया कि हम बात करते हैं सिर्फ अपने हेल्थ की नहीं, हमें अपनी इंट्रासेक्टोरल कोऑर्डिनेशन तो करना ही है। इंटरसेक्टोरल कोऑर्डिनेशन इज वेरी इंपॉर्टेंट, लाइक वी टॉक्ड अबाउट द एजुकेशन। स्कूल हेल्थ स्कीम चलता है, उसके अंदर बच्चों का ओरल एग्जामिनेशन होता है, उसके अंदर उनको वैक्सीनेशन की एडवाइस दी जाती है। सो हमको दूसरे सेक्टर्स को भी इन्वॉल्व करना है। WCD, विमेन एंड चाइल्ड डेवलपमेंट डिपार्टमेंट, दे कैन ऑल्सो हेल्प। देयर आर वेरियस प्रोग्राम्स जो हमारे besides national program of non-communicable disease, which are also having multiple overlapping areas for this program. So उसके लिए like हमने बोला कि नेशनल ओरल हेल्थ प्रोग्राम है, so उसमें भी हमें स्क्रीनिंग में हेल्प मिलेगा, नॉट ओनली बिकॉज ऑफ द NCD प्रोग्राम वी कैन डू। जितने लोग ENT स्पेशलिस्ट को विजिट करते हैं, दैट इज एन अपॉर्चुनिटी। तो लोगों की सर्जरी जब भी होती है, एनेस्थीसिया दिया जाता है, एनेस्थेटिस्ट हमेशा उनके मुंह में झांकते हैं। So everybody, if they are sensitized that whenever there is an index of suspicion, it has to be flagged. वहां पर उस लेवल पर नहीं छोड़ना है। मैंने लेरिंगोस्कोपी किया, आई कुड सी सम सस्पिशियस लीजन, लेकिन मेरा काम तो सिर्फ वो सर्जरी कराना था और मैंने छोड़ दिया। सो दैट शुड नॉट बी डन। सो उसके लिए अवेयरनेस इज इम्पोर्टेंट। सो इंटरसेक्टोरल इंट्रासेक्टोरल अवेयरनेस होगा तो नोडल ऑफिसर्स का बर्डन कम होगा, एफिशिएंसी बढ़ेगी, आउटकम इम्प्रूव होगा, ओवरऑल प्रोग्राम बेटर होगा, ओवरऑल मॉर्बिडिटी कम होगी, मोर्टेलिटी कम होगी, विल हैव मोर people contributing to the GDP of the nation. So overall हमारी country का status भी improve हो जाएगा। So ultimately we have to see everything in a total holistic manner. Don't restrict to one small little thing. Now public awareness poor है, so हमें influencers चाहिए जो आपके patients जो cure हो गए। लाइक हमने बात की कि अब कैंसर को ऐसा नहीं माना जाता कि इसका इलाज है, इलाज ही नहीं हो सकता, क्योर होता है। जो क्योर हो गया, दैट पर्सन कैन एक्ट एज अ वेरी गुड इन्फ्लुएंसर फॉर द कम्युनिटी। कुछ टबूज हैं, कुछ स्टिग्मा है, क्यों हो गया, सर्वाइकल कैंसर हो गया, पता नहीं सेक्सुअली ट्रांसमिटेड होता है, कुछ ना कुछ हुआ होगा, वो स्टिग्मा हटाना है, उसको अर्ली डिटेक्शन इज इम्पोर्टेंट। इसी तरह से हमारा जहां पर भी हमारी रिलेटेड IEC, रिलेटेड एजुकेशन, रिलेटेड कम्युनिकेशन का हमें जहां जहां अपॉर्चुनिटी मिलता है उसको हमको आगे स्प्रेड करना है। क्रॉस कटिंग चैलेंजेस तो लाइक अनएक्सपेक्टेड, जो हमें पता ही नहीं होता, कोविड आ गया सडनली, सो ऑल द एक्टिविटीज वर मॉडिफाइड everything was focused on containment of the pandemic. इसी तरह से बहुत सारे जब हमने बात की इन्फ्लुएंसर्स की, जैसे हमारे इन्फ्लुएंसर्स पॉजिटिव इन्फ्लुएंसर्स हैं, ऐसे बहुत सारे नेगेटिव इन्फ्लुएंसर्स भी हैं कम्युनिटी में, बट दे हैव generated so much of confidence among the community, so it is very difficult to write them off like that. उस टाइम पर हम क्या कर सकते हैं? सो एक छोटा सा एग्जांपल आपको बताती हूँ, which is not related to cancer. होम डिलीवरीज घर में हमें बंद करनी थी, बट देयर वर लॉट्स ऑफ होम डिलीवरीज व्हिच वर हैपनिंग एंड मेनी guys were conducting home delivery and they were telling the vulnerable pregnant women, भाई तुम अस्पताल में जाओगे तो मर जाओगे, मैं तो घर में ठीक कर दूंगी. सो हमने क्या किया, उन दाइज को वी ट्रेन्ड द दाइज एज आशाज. सो नाउ दे फ्रॉम बैड इन्फ्लुएंसर दे themselves acted as our resources. इसी तरह से जितने भी आपके पास क्वैक्स हैं, उनको अगर आप प्रॉपरली गाइड करते हैं, ट्रेन करते हैं, सो दे हैव लॉट्स ऑफ फॉलोअर्स. सो वही आपके नेगेटिव इन्फ्लुएंसर्स कैन बी यूटिलाइज्ड एज द पॉजिटिव इन्फ्लुएंसर्स इन द कम्युनिटी. So I think we have already discussed that in the because of the constraint of time we can just leave this. But important thing is कि हमारे कुछ टारगेट्स हैं जिसको हम मीट नहीं कर पाए थे पहले. हमने बात की थी 2020 तक हमने डिसाइड किया था कि कुछ पैरामीटर्स मीट करेंगे which could not be done. So अभी आगे का क्या है? हमारे पास ये है कि 30+ पॉपुलेशन 80% स्क्रीनिंग हो जाना चाहिए. Early diagnosis within 30 days of positive screening should be done. All the frontline workers, ASHAs, ANMs should be 100% trained for the screening, for the IEC, for the communication, for the spread of information. But सिर्फ उनको ट्रेन करने से काम नहीं चलेगा एक बार. So equally important is their supervision. आशा दीदी क्या बता रही हैं, उनको कितना समझ आया, उसको एएनएम दीदी ने आके देखना है, सुपरवाइज करना है. एएनएम को सीएचओ ने सुपरवाइज करना है, मेडिकल ऑफिसर्स ने करना है. So at every level it has to be a reinforced supervision. हमने बात की है कि कीमोथेरेपी यूनिट्स, डे केयर सेंटर्स ऑलरेडी एस्टेब्लिश होने शुरू हो गए हैं. दिल्ली में 4 हमारे डेजिग्नेट हो चुके हैं, बाकी स्टेट्स में भी ये सब चल रहा है. Now it has to be linked to the global targets. सस्टेनेबल गोल्स हमारे SDG 3 में हमारा एक गोल ये है कि प्रीमेच्योर NCD मोर्टेलिटी शुड बी रिड्यूस्ड बाय 1/3 बाय 2030. 30% कम हो जाना चाहिए. एंड कैंसर इज अ मेजर कंट्रीब्यूटर टुवर्ड्स द प्रीमेच्योर NCD मोर्टेलिटी. अगेन यूनिवर्सल हेल्थ कवरेज हमको अचीव करना है और हेल्थ वर्कफोर्स को भी हमको स्ट्रेंथन करना है एट एवरी लेवल. वी कैन नॉट अफोर्ड टू हैव अ सिंगल वीक लिंक. हमें सारी कड़ियां मजबूत करनी है, कम्युनिटी से लेके टर्शरी केयर तक एंड फ्रॉम टर्शरी केयर बैक टू द कम्युनिटी. क्योंकि उसके बाद या तो पैलिएटिव केयर आ जाएगा या तो फिर ट्रीटेड पेशेंट आ जाएगा जिसको आगे रेगुलर फॉलोअप चलता चला रहेगा. सो द साइकिल विल बी कंप्लीटेड दैट. सो अब हम इसके लिए आगे क्या कर सकते हैं? सबसे पहला तो हमारी पॉलिसी में ऑलरेडी आ गया है, डिसेंट्रलाइज करना है, ऑफलोड द टर्शरी केयर सेंटर्स, ऑफलोड द लिमिटेड डिस्ट्रिक्ट हॉस्पिटल्स जहाँ पर कैंसर का ट्रीटमेंट हो रहा है, और उसको एटलीस्ट स्क्रीनिंग पार्ट, एटलीस्ट इनिशियल ट्रीटमेंट पार्ट, बेसिक ट्रीटमेंट पार्ट विल बी डाउनलोडेड टू प्राइमरी एंड सेकेंडरी. वर्कफोर्स हमारे पास जितना है, अगर उनको नॉलेज है अच्छी, so they will be able to act more efficiently. So it is very important that 100% of our staff is not only trained, they should be properly intensivized. So incentive उनको कैसे मिलेगा? Incentive can be monetary, incentive can be non-monetary as well. Non-monetary incentive works much better as compared to the monetary incentive. अगर किसी कम्युनिटी में किसी एक हेल्थ केयर वर्कर को हम उसको फेलिसिटेट कर देते हैं, उसको अवार्ड देते हैं, हम इंडिपेंडेंस डे पे, रिपब्लिक डे पे, किसी बड़े फेस्टिवल पे, कभी दिवाली के टाइम पे, So it gives a very, very positive reinforcement, and they work with double the zeal. Not only they work with double the zeal, they start the cascading of the training center, training of the cascading of the knowledge to everybody with whom they come in contact. Again, the digital system, we have said that there are so many portals now which are very user friendly. Will not go into the detail of the portals, but NCD portal है, MIS है, and then all other portals. जब हमारे ये portals properly utilize होंगे, then only we'll be able to say that we are able to put the information into the cancer registry. So we have not talked about the cancer registry. This started way back, लेकिन registry बहुत ज़्यादा incomplete है. कुछ private hospitals में या cancer hospital से उनके पास data चला जाता है. But need of the hour is real time cancer registry. जिस टाइम आपने सस्पेक्ट किया, जिस टाइम डायग्नोज हुआ, उसी समय पर आगे जाए, डेटा अच्छा सा मिलेगा, पॉलिसी अच्छी सी बनेगी, रिसोर्सेज अच्छे से बनेंगे, अच्छे से डिस्ट्रीब्यूट होंगे, and then only everybody will be able to work in a more efficient manner. It will start a chain reaction of efficiency. Community engagement तो हमने बात किया है, and we have already said that multi-sectoral involvement is very important. एक पेशेंट को आपको विलेज से आगे भेजना है, रेफर करना है, पेशेंट कैन नॉट अफोर्ड, यू हैव टू हैव intersectoral coordination with the transport department, rural development department. So these are the important aspects which will help us in overcoming all the challenges. So whatever we want to do, we need to do an effective implementation. We want the good results, and what we want is, we want that ultimately हमारा आउटकम बहुत अच्छा, और आउटकम अच्छा है कैसे पता लगेगा, व्हेन वी हैव मेजरेबल आउटकम इंडिकेटर्स. सो हमें अपने इंडिकेटर्स हमेशा मेंटेन करके रखने हैं, एंड वी हैव टू कंपेयर विद द प्रीवियस मंथ्स. जो भी प्रीवियस मंथ, क्वार्टर, हर एक इंडिकेटर का अपना अपना टाइम है. सो ऑल द इंडिकेटर्स, एवरीबडी इज अवेयर, दोज आर आल्सो अवेलेबल इन द गाइडलाइंस. So in the constraint of time, I don't think I can proceed further and give you the details of the indicators, but definitely I will request the NHSRC team to share the documents with you. And जैसे डॉक्टर कालरा ने अभी बोला है कि किताब में सब कुछ लिखा हुआ है कि कैसे आपने स्टेजिंग करनी है, उसके बाद स्टेजिंग के बाद it has become very mathematical and you can start the treatment according to the guidelines, SOPs and algorithms given. Similarly, all these indicators are also available, but what you need to do is you need to capture the correct data, put it into the formula, find out the indicator and see how you increase bit by bit. So together we definitely can beat cancer, and we have to be winner in that. So that's all from my side. And if there are any questions, we are more than willing to take, depending on the permission from NHSRC team in the constraint of time. So over to Team
Thank you
NHS,
so much.
please.
Thank you so much, ma'am, for such a wonderful session. Ma'am, few questions are there.
Yes. So we'll be taking the questions. I can't see any question pertaining to this session. There were certain more which we have already addressed.
No, there is no questions now for this session, ma'am. We'll share the all the resource material through mail
Absolutely.
for the
Absolutely.
participants who have registered.
Okay, ma'am, before moving forward, I would like to extend my heartfelt gratitude to our Executive Director, Executive Director Sir, Advisor Sir, Group Captain Dr. Rajiv Patni Sir, Dr. Vandana Bagga Ma'am, our guest faculties Dr. Pallavi Shukla Ma'am and Dr. Kaushal Kalra Sir, and all the dear participants who joined us for today's webinar. Your active presence and engagement made this session truly meaningful. And before concluding this webinar, I would like to inform you all that the links for feedback, post-test, And also the previous STG webinar series videos have been provided in the chat box. I kindly request you all to visit these links. And the upcoming webinar would be on 20th September 2025. The topic would be diagnosis and management of viral hepatitis, along with the managing mild neonatal jaundice in domiciliary setup. I hope to see you all participants in the next session. And thank you so much for being with us today. Thank you.
One question I saw in the chat box right now. So that question was about the 5 A's and 5 R's.
Yes, ma'am.
So 5 R's basically was for the cessation of smoking. So the R's are relevance, risks, rewards, roadblocks, and a repetition. So the relevance of the smoking, unless the smoker knows what is the relevance of stopping the smoking, cessation of smoking, they will not be motivated. So they have to be told that you can cause by passive smoking, you can harm the newborn child that you have in your family. You can harm the elderly people who are available, who are staying in your parents, other things. Then risk is the risk of smoking, health risk, financial risk, other risks that they are facing, so that they get convinced that they have to do the cessation of smoking exercise. Rewards, again, if they stop smoking, what is there to gain? So they will be spending less on the not only the cigarettes and other smoking material, they will be spending less on the healthcare budget also. And better health means they can have a better quality of life, better time with their family, better productivity in their workplace. So these all will be part of the rewards. Roadblocks are, again, somebody may not get convinced. Why? If I stop, then it may not happen. So we have to see what could be the possible roadblocks which will not, मुझे तलब होती है, मैं नहीं छोड़ पाता. So that would be one of the roadblock. मैं peer pressure में मुझे पीना पड़ता है, साथ में सब friends बैठते हैं तो मुझे करना पड़ता है. So we have to find out a solution for the roadblocks. And last is repetition. So all 4 steps have to be repeatedly told to the person, so that they get convinced that they have to stop the smoking or cessation of smoking. So this was about the 5 R's. 5 A's was for the not the treatment of malignancy, but to overall management, not pertaining specifically to the treatment part. So that is assess, advise, agree, assist, and arrange. So one has to assess, जो हमने initial screening की बात की थी. After that, advise. So you have to tell the available modalities available for the management of that symptom. Agree means then you have to take the person, the patient or the patient's family or the people who are responsible for managing the disease to come to a consensus. Okay, ये इलाज हम कर सकते हैं, उसको दाखिल होना पड़ेगा, उसको कीमोथेरेपी देनी पड़ेगी, उसके साइड इफेक्ट्स होंगे. So both the parties have to agree, the service provider as well as the service receiver. Then assist is, once they agree, then you have to assist them in getting the treatment. And after you assist them, then you have to arrange for if they need to be sent to a higher center, then how do they reach there? They don't have the resources, so you have to arrange for other modalities like transport, like some NGO who can arrange for the stay in the different area. So things like that. So these are the 5 A's and 5 R's. So that's all from my side.
Thank
So
you so
back
much, ma'am.
to Mrs. RC.
Thank you so much, ma'am.
So can
Are we good to end this session, ma'am?
Absolutely, and my heartfelt thanks to the whole NHSRC team, and Dr. Srivastav and Dr. Kotwal are not there, and our upcoming advisor, because I know Dr. Srivastav would be attached always with the quality, but I think Dr. Patni will be taking over from the next one. So my heartfelt thanks to all. The team NHSRC, because you are always working in a team. Thank you so much.
Thank you so much, ma'am. Thank you. Thank you, everyone. Thank you.